Good afternoon, everybody. Welcome to this webinar on acoustic schwannomas, evidence-based treatment, organized by HCG. And I want to begin by complimenting Dr. Shankar for putting together such an eminent panel of speakers from across the country. Acoustic schwannomas are really something which bother most of us who treat, and today's webinar covers a very large range of problems of treating acoustic neuromas, beginning with imaging. I have now great pleasure in requesting Dr. Shilpa Sankhe from Zankaria Imaging Center, Mumbai, to kindly start her presentation. Dr. Shilpa, please.
So thank you everyone, Dr. Shankar, for this opportunity. I shall be speaking on radiology of CP angle lesions. And when we talk about CP angle lesions, so the first sequence which we really look at is this Cis sequence, that is constructive interface at steady state. And when we are looking at the cisternal space in the CP angle cistern, we can see the facial as well as vestibular cochlear nerves very well. So what is this Cis sequence? It is basically a brand name and it has several other names like Fiesta, Thrive. And it is a sub-millimeter 3D T2 sequence. Because here when the CSF is really bright, we can see the nerves stand out very well. The arteries are also seen, but these are dark and we know the expected anatomy of the vessels. So we can see the nerves very well. For example, now in this image, what we can see is we can see the facial nerve and anteriorly and the superior vestibular nerve. One section inferiorly, we continue to see the facial nerve, but we see the vestibular cochlear nerve with the cochlear nerve superiorly. So you can see the facial nerve and you can see the vestibular cochlear nerve. And the cochlear and the inferior vestibular nerve. We have seen the superior vestibular nerve or a section above it. In this sequence, not only can we see the nerves, but we can also see the inner ear structures, which includes the cochlea, the vestibule, semicircular canals. So we have a good idea of what's going on in the 7th, 8th nerve complexes. So how can we image the nerves? 3 Tesla imaging is the best to image 7th, 8th nerve. In fact, any nerve. 1.5 Tesla system is also good enough, but below that you get poor quality images. Cis, Fiesta, Thrive sequence remain the mainstay of any nerve imaging. Diffusion weighted image to see for tumors and also for lesions such as epidermoid, which will show restricted diffusion. Angio, wherever relevant, contrast is generally needed, and DTI is research based, however, can be used to see the individual components of the vestibular cochlear nerve. So broadly, CP angle lesions can be divided into neoplastic and non-neoplastic etiology. In neoplastic etiology, schwannoma tops the list, followed by rest of the lesions as I have enumerated, and which I will, most of it, of the images I will be showing in the coming slides. We move on to the most important image, and that is of the CP angle system, and that is acoustic schwannoma. So the first image is a Cis image and the second is a post-contrast axial image. We can see that there is a lesion, ice cream cone appearance in the left IAC. This is involving the 7th, 8th nerve complex, and widening of the porus acousticus is seen and intracanalicular extension is also demonstrated. On the right side also there is a lesion. This is intracanalicular mainly with a very small cisternal component. So this is an example of an NF2 and a typical appearance of an acoustic schwannoma. So as I have said, the porus acousticus is widened, very typical for an acoustic schwannoma. In NF, there is bilateral involvement. Unilateral involvement may be seen, but then the other, there would be many meningiomas, etc., which would fulfill the criteria. Trigeminal nerve involvement is also seen. For example, in this case, you have bilateral acoustic schwannoma The third nerve is also involved, and so is the trigeminal nerve bilaterally. This patient also had multiple spinal schwannomas. Once we are talking about schwannomas, here in this scenario, I thought I would should include post gamma knife appearance in schwannoma, whatever little experience I have had so far. So post gamma, this is the same appearance, and this is the post gamma knife appearance done 3 months after the surgery. So what do we see here? There is near homogeneous enhancement, and there are few non-enhancing areas. While in the post-treatment appearance, the lesion is slightly enlarged. There is cystic appearance and central necrosis. So though the lesion may enlarge, the necrosis and non-enhancement of the central part is indicator of a better prognosis. And if you image them, typically after 6 months, they would shrink after 6 months, that is. Not to forget trigeminal schwannoma, which can also be present in the CP angle cistern. However, these are bilobed, typically straddling the prepontine cistern with a dumbbell shape appearance as against ice cream cone appearance in 7th-8th nerve complex tumors. Rest of the characteristics are similar. There is a distinct role of SWI in distinguishing between a CP angle schwannoma and a meningioma. These are the images taken from a journal because I could not find lesions which could, the schwannoma and meningioma, which would look similar to each other and thereby provide a teaching point. So the image on the left side is that of schwannoma. You have a Swi sequence and the post-contrast image showing ice cream cone appearance and punctate foci of petechial hemorrhages are seen in schwannoma. As against meningioma, the lesion is dural base, so the CP angle cistern is significantly effaced if you compare with that of schwannoma, and the dural base is seen very well on the post-contrast image. This is also extending into the canal, but what we don't see is petechial hemorrhages, and instead of that, we see a central calcification, very typical of a meningioma. These are phase contrast images just to highlight the petechial hemorrhages. So this is the article from AJNR, and the intratumoral microhemorrhages on the cyst, they help in distinguishing from vestibular schwannoma from meningioma. So coming to meningioma, these are the second most common tumors seen in the CP angle cistern. As against the previous example where we saw extension into the IAC, this does not have extension into the IAC but has typical homogeneous appearance.
Dr. Shilpa, sorry to interrupt you.
Yeah.
We have over 500 participants. Correct. And many of them are postgraduates. So for their benefit, could you just use full forms? What is SWI, for example?
Okay. Fine. So SWI sequence is the susceptibility weighted image, which is possible with a higher end 1.5 or a 3 Tesla, and which would show presence of calcification or hemorrhage. So we could see the hemorrhages in this acoustic schwannoma as against meningioma, where we do not see any petechial hemorrhages. Moving on to meningioma, there is these typically show homogeneous post-contrast enhancement, a dural tail, and they can encase vessel as against schwannoma, which will displace vessels. Also in meningioma, the enhancement will be homogeneous as against schwannoma, which will have areas of cystic degeneration or sometimes peritumoral cyst as well. Another example of a CP angle tumor, not necessarily in the cistern, but in the CP angle, is a hemangioblastoma. This is a case of VHL where we see these are the axial T2 and post-contrast images showing a solid lesion with some areas of hemorrhage as well. And you can see the solid lesion. Also, you can see in the inner ear the endolymphatic sac tumor, which you can see this is enhancing. So this is a typical example of a hemangioblastoma. That's the sagittal image. On the coronal image, you could see nodular enhancement and other hemangioblastomas as well. Same patient, spine showing conus medullaris hemangioblastoma with multiple serpiginous areas of enhancement suggestive of associated vessels due to increased vascularity. Same patient, this is the HRCT appearance of an endolymphatic sac tumor typically seen in hemangioblastoma. We have a companion case This is also a hemangioblastoma. It's a completely solid hemangioblastoma. This patient was not a case of VHL and presented with this lesion in the CP angle. It was extremely solid, T2 dark, as against acoustic schwannoma, had IAC extension like acoustic schwannoma, but had multiple areas of flow voids, suggestive of vessels within and around the lesion. That's an axial and that's a core T2. Post-contrast image revealed intense enhancement of the lesion, and this patient actually came for a post-operative imaging, and we asked for the pre-operative MRI. This is the post-operative, which shows near complete excision. The 7th-8th nerve complex is well visualized, and this was the histopathology report. So hemangioblastomas could be solid, could have IAC extension, just like schwannoma or meningioma, but vessels and vessels within and around the lesion and a very, very solid appearing lesion is the clue. Coming to T1 hyperintense lesion in the CP angle system, these are axial T2 and T1 weighted image. This is an iso to hypointense lesion, bright on T1 weighted image. And this was non-enhancing on contrast. This is a typical example of an endodermal cyst. Typically anterior or anterolateral to the pons or medulla. These are developmental lesions and benign lesions basically. Other example of a T1 hyperintense lesion, this is also looking similar, but this is showing intense enhancement, slightly more aggressive looking. If you see the coronal image, there is extension into the internal auditory canal on the T2 as well. And this actually came out to be pigmented benign meningeal melanoma. It was compressing the cisternal segment of the trigeminal and the 7th-8th nerve complex. Patient presented with trigeminal neuralgia and had complete recovery post-surgery. Since we are talking about developmental lesions in the CP angle cistern, epidermoid cyst cannot be far behind. It is one of the very common lesions in the CP angle cistern. T2 bright, typically restricted diffusion, contrast to rule out other lesions, and as I said, diffusion weighted image is enough, and in post-contrast study is not needed for post-operative evaluation, and wherever there is restricted diffusion, that is indicative of a residual tumor. So that is very, very vital.
Dr. Shilpa, sorry to interrupt. You have to finish in the next 30 seconds, please. Your time is
Yeah, but I think there was it was startup delay. So I guess just a minute. Yeah. So what about this lesion in the CP angle system? This is also broad-based, exhibiting restricted diffusion, but there is perifocal edema there. And on the CIS image, you can see it is extending into the IAC with homogeneous enhancement. This was an example of metastasis from bronchogenic CA. This is another example of a metastatic lesion involving the petrous apex, not involving the nerves, but indenting the 7th-8th nerve complex. What about this lesion? It showed restricted diffusion. This was the SHH variant of medulloblastoma with extreme nodularity. So these desmoplastic medulloblastomas can also occur in the CP angle cistern. About pontine gliomas, this is an eccentric glioma seen in the CP angle cistern with heterogeneous enhancement, and DTI showing displacement as well as destruction of the tracts. Bony tumors such as chondrosarcoma can also be seen in the CP angle cistern. However, they appear typically with ring and arc pattern and some hyperintensity on T1 weighted images. So we have seen most of the neoplastic lesions, and just 2 slides to show non-neoplastic etiology. Facial neuritis, sometimes patient presents with Bell's palsy and patients come to image this, and what we see is enhancement in the intracanalicular segment of the 7th nerve. Well seen on the coronal image, the facial nerve is on the top and the 7th-8th nerve complex below. So you can see that enhancement there. And in some cases, you can see vascular loop. Patients present with hemifacial spasm. The transitional zone is much distal as compared to the 5th nerve, which is more proximal. So you could have patient may present with hemifacial spasm, and there you can see the dot. that ICA, which is crossing over the 7th, 8th nerve complex. And thank you for your attention.
Thank you, Dr. Shilpa. That was a very nice presentation. We now move on to the next one, which is NF2 and bilateral acoustic schwannoma, Art of Decision Making, by Professor RajShekhar from CNC Vellore. Professor RajShekhar, please. And you have 20 minutes.
Good afternoon, and thank you, Dr. Shankar, for this invitation. What I plan to do is to take you through a series of about 8 cases to sort of illustrate the complexity of decision making in patients with NF2 with bilateral vestibular schwannomas. So what are the decision altering factors? There are 3 decision altering factors to my mind in a patient with a bilateral vestibular schwannoma. One is brainstem compression, second is hearing, and the third is the presence of other tumors. So as far as brainstem compression is concerned, you could have tumors on both sides which are compressing the brainstem. Brainstem compression is an important component of the decision-making process. So you could have a situation where both the tumors are compressing the brainstem, one being larger than the other, or both being of the same size. You could have a situation where one tumor alone is compressing the brainstem, the other one is small, or a situation where neither tumor is compressing the brainstem. The second major factor to be taken into consideration is the hearing function. So you could have both ears having functional hearing, or only one side having functional hearing with either a larger tumor or a smaller tumor, or both ears being completely deaf. Finally, of course, you could have other tumors such as meningiomas and other schwannomas also present. So I know it sounds very confusing, but just look at the management principles. I'll try to simplify it. First of all, preservation of life scores over all other considerations, and that comes with the presence or absence of brainstem compression. So whenever the brainstem is compressed, life is at risk. So you need to go with that first. The second consideration after you have dealt with that is hearing preservation. You need to preserve hearing as long as possible in these patients. Ultimately, these patients are going to go deaf, completely deaf in both ears. So use this time available to make these patients functional, either by asking them to learn lip reading or sign language. Thirdly, with whatever intervention you do, never produce bilateral facial palsy, because that is devastating to the patient and because the patient cannot eat. So try and avoid that. Finally, remember, you have these 3 or 4 options. 1, don't do anything. 2, operate on these patients. 3, give them stereotactic radiosurgery or stereotactic radiotherapy. So I'll begin with the case that we have handled. The first is an 18-year-old male who presented to us in quite a sick condition with raised intracranial pressure, as you can see, with hydrocephalus here, and with these 2 very large tumors causing swallowing dysfunction and, of course, bilateral deafness. He was on a nasogastric tube before surgery. We decided to operate on the larger tumor, the left side one, and a few months later, we went ahead and operated on the right-sided tumor. So this is after we took off the left-sided tumor, and then we went ahead and took the right-sided tumor off, and we have left some tumor on both sides, the right side and on the left side. We advised this patient to come back for follow-up for radiosurgery, but this patient was lost to follow-up, unfortunately. And you can see that the hydrocephalus is resolved, so the patient has benefited from this surgery. The second case is a 26-year-old female with bilateral sensory neural hearing loss, and the right-sided tumor being larger. We operated on that, removed that, and advised stereotactic radiosurgery for the left-sided tumor, but she did not come back for follow-up, came back to us after 6 years The tumor has increased in size, and therefore we had to operate on this. We operated on that, left that small residue, gave stereotactic radiosurgery, and this is the follow-up in 2014, a year after radiosurgery. The third patient is a 20-year-old male with a left-sided sensory neural hearing loss, right-sided hearing being normal. The tumor, fortunately for us, was larger on the left side, the same side that the patient has lost hearing. We excised it. Unfortunately, we couldn't preserve the facial nerve, ended up with a tarsorrhaphy, but did not come back for follow-up as advised to treat the right-sided tumor, and came back to us 3 years later with a large right-sided tumor. Was advised surgery now because this is too large for radiosurgery, but unfortunately was lost to follow-up. Another 18-year-old girl with bilateral sensory neural hearing loss. 2004, we excised the left-sided tumor. We produced a facial palsy, underwent tarsorrhaphy, was advised radiosurgery for the right-sided tumor after 3 months, but came to us after 8 or 9 months. And you see what has happened to the tumor. This is the same size in both slides. You see the tumor is filling this whole circle here, whereas it was only 50% of the circle in 6 or 7 months, 10 months ago. So this is something that we must anticipate, rapid growth of tumor in a patient with neurofibromatosis type 2. So we had no option but to operate on this case. It's causing brainstem compression. We left a shell of tumor to preserve the facial nerve. Don't give radiosurgery at this point because this is not a good target. Wait for 3 months like we did, and you see that the shell has folded on itself to make a nice radiosurgery target. We did that, and this is a follow-up in 2014. That is 9 years later. We were very happy with the outcome. The patient was happy, but this is not the end of the stories. You see this at 15-year follow-up, 2019. See the number of tumors that have come up. Just to show you, in 2014, no meningiomas. Now you see there are so many tumors. This has again probably progressed, or another meningioma has come up there. And this is a common story in these patients, new tumors coming up. Case number 5. We have this 13-year-old girl, bilateral hearing loss, right-sided tumor being very large, left being small. But what I want to highlight is this small tumor here. That's actually a facial nerve schwannoma. We excised the vestibular schwannoma, but left the facial nerve schwannoma, obviously, and we produced a facial palsy. We gave radiosurgery to the left-sided tumor in 2009, a few months later, but she did not come to us for follow-up since 2011. She came to us in 2018 with a left-sided lip swelling, and you see what has happened to the right-sided facial nerve schwannoma. That has increased in size, again excised through the middle fossa root, and we have left a small amount of residue for both the facial nerve and the vestibular schwannoma, which has grown in size. We gave radiosurgery to this patient for that residue. Here is a case where you have tumors which are neither of which is compressing the brainstem, except that if you look carefully at this patient's tumor on the right side, you have what is called as a collision tumor. You have a vestibular schwannoma coming out of the porus, and you have this tumor which is compressing the brainstem slightly, which is actually a meningioma. You can see that again in this Gadot enhanced picture. This is the meningioma, and that is the vestibular schwannoma. You also have another meningioma here. We operated on this patient, took out both the vestibular schwannoma and the 2 meningiomas. We did produce a right-sided facial palsy and did tarsorrhaphy for that. So this is the picture after a year where it shows good excision of the tumors on the right side. The left-sided tumor is there. 2013 showed tumor on the left side growing. So we gave radiosurgery for her. She's deaf in both ears, and at 8 years, you see that the tumor is fairly well controlled on both sides. Case number 7, a 25-year-old female with bilateral hearing loss. Again, small tumors, not compressing the brainstem. So we decided to give radiosurgery for the side where the hearing loss is worse, that is the right-sided tumor. We have not done anything for the left-sided tumor because she's still got hearing on that side, and we are waiting and following up and to decide on what's to be done for that. Finally, again, another patient in whom we have bilateral small tumors with only mild to moderate sensory neural hearing loss. Left is slightly more involved as far as hearing is concerned, but you see that the right-sided tumor is slightly larger. We decided not to do anything for this patient. This patient also has got other tumors there, and we are following up this patient. So this is literature on what to expect with radiosurgery for these tumors. What is seen from the control rate is that it is slightly worse than what is to be expected following radiosurgery for sporadic vestibular schwannoma or unilateral vestibular schwannoma. It's not too bad, but still the rates are lower, the control rate, 66% for example in this series. Of course, it's really bad in this series, but most report around 80 to 90%. So generally, results of radiosurgery are worse in patients with bilateral vestibular schwannomas compared to a sporadic vestibular schwannoma. Again, one more point to be noted is that the risk of malignant change after radiosurgery seems to be slightly higher in patients with neurofibromatosis type 2. So how do you choose the intervention? Let me summarize. If there is brainstem compression, you need to operate on the patient and take out this tumor which is causing the compression. Sometimes it's just one side, sometimes it's both sides, but you try and preserve the facial function at least. Unlikely that you'll preserve hearing function. As far as hearing loss is concerned, avoid interventions on the side which has got this serviceable hearing, unless of course it's also the side where the brainstem is being compressed. So brainstem compression finally decides whether you need to operate or not. You do surgery or radiosurgery for the worst affected ear when compression is not an issue when you're looking at hearing. Finally, you do radiosurgery for residual or non-compressing tumors. So basically, I want to conclude by saying that you individualize management of patients with bilateral vestibular schwannoma. There is no one size fits all. So it's a combination of various modalities. Remember, the radiosurgery may not work as well as it does in sporadic vestibular schwannomas, although the dose that you choose, that is around 11 to 12 or 13 gray, is the same. I tend to choose a little lower dose, maybe a gray less, covering dose-wise in patients with NF2. But the most important thing is that these patients require a lifelong follow-up, as I have shown, because new tumors can come up. And this is a major challenge in our patients. Thank you for your attention.
Thank you, Professor RajShekhar. That was a wonderful presentation. You brought forth all the complications which can occur, about the hearing loss, which is so important, and I think both graduates will find it very, very useful. We will now move on to the next presentation, which is AS, radiosurgery, indications, technique, and results by Professor Dev Pujari of the Bombay Hospital, Mumbai.
Okay, so basically, I think I'm sorry. I mean, if Dr. Mishra had done his talk on evidence-based medicine, it would have been much easier for me to give this talk. But I'm sure we'll probably be able to hear him later. So my task today, Shankar has given me a talk on indication, techniques and results on vestibular schwannoma, and as RajShekhar spoke before me, I think I'm going to mainly restrict myself to sporadic schwannomas. So basically we know that the nomenclature varies from acoustic neuromas, schwannomas, neurinomas, neurilemomas, etc. But we all mean what is now universally accepted nomenclature as vestibular schwannoma. And Shilpa has shown us very nicely, but for treatment purposes, we talk about intracanalicular grade and then further severe compression causing hydrocephalus. So Coos has divided this into these 4 categories, and that is the natural evolution. And Professor Sami has given another classification which tells us the various areas getting compressed, and all of us actually grown up with the idea of doing microsurgery for this, usually by retrosigmoid, but because most of the tumors which we see are large, and are very happy to see a smiling patient at the end of this operation, and we try to achieve this, and that has been our goal when we were training. Surgical technique, of course, apart from the retrosigmoids, that is the retromastoid suboccipital route, we also have a translabyrinthine route which has been popularized by ENT surgeons, and they are good for even large tumors, especially when hearing preservation is not an issue. And the facial preservation rate seems to be better with this approach, while the middle fossa approach, if the tumor is reasonably small and the hearing has to be preserved, is the preferred approach for many. SRS became a big player towards 90s, and as many of you already know, that stereotactic radiosurgery is a technique that utilizes multiple convergent beams to deliver a high single dose of radiation to a radiographically discrete treatment volume, and therefore restricting injury to the surrounding structures. The three common equipment which is available to us is the Lexel Gamma knife, the Cyber knife now, and the Linac or what is popularly known as X-knife radiation. Now, if you look at meta-analysis as to what has actually happened now that we have enough experience with radiosurgery of more than 25 years and several years of microsurgery, the modern way of treating the acoustic neuromas is a recent meta-analysis which tells us that microsurgery can control the tumors quite well, but the hearing rates are probably similar in both, with hearing preservation rate of 39 to 70% in microsurgery and about 40 to 80% wherever there is serviceable hearing earlier. And the facial neuropathy rate is greatly varying depending on the surgeon. So basically, tumor control rates are probably good, but the hearing preservation and the facial neuropathy is highly dependent on the experience of the surgical team and intraoperative neuromonitoring recently compared to the more standard kind of hearing preservation rate of about 40 to 60% in the radiosurgery group and very minimal facial injury group in the radiosurgery group. We'll go into the details of that over the period. There is, of course, a small mortality rate in surgery in very, very large tumors, and there are some other complications like cerebrospinal fluid leak, which can be of nuisance value, but occasionally can be threatening, life-threatening because of meningitis, etc. And the non-audio facial neurological complications are seen in about 9% of patients in a meta-analysis of about 32,000 patients. So basically today, if you look at it according to the Coos grade, you have a grade 1 tumor that is below 10 millimeter intracanalicular. Radiosurgery seems to be a good option or probably the first option. Same may be in grade 2, and there are of course nuances in this depending on the preserved hearing, your ability to do the middle fossa surgery, etc. But very commonly acceptable is up to grade 3. You can still continue to do radiosurgery, but many of us see grade 4 patients with brainstem compression, and their microsurgery becomes our first treatment. So how has the stereotactic radiosurgery progressed? I think if you look at the early experience, you will find that when the dosages of 20 plus grays were initially given, you had a very good local control rate of 95%, but the cranial nerve toxicities were almost to the tune of 90%, and hearing preservation was very, very low. And because of this low hearing preservation rate and fairly severe facial and trigeminal neuropathies in about 1/3 of the patients, the dose reduction took place, and this started somewhere around 90s, and we have several now series which have shown that the hearing preservation rate as well as the facial trigeminal neuropathy has considerably reduced. And today, if you look at the fact that today's paradigm has become 12 to 13 gray, and we have come down to the fact that over 25% hearing preservation rate at about 10 years, but initial preservation rates for first 2 to 3 years are 60 to 70%, and the facial and trigeminal complication rates have come down below 5%. Now, is it all because of the cochlear radiation dose or not? Is not very clear, but many people feel that the cochlear radiation dose is probably predictive of hearing outcomes. And there are several individual series which have now shown that the local control rate is universally somewhere about 95%. The cranial nerve preservation rate is also about 95%, while the hearing preservation rate is upwards of 65% if there is a serviceable hearing. So today, I think all newly diagnosed tumors which are below 3 centimeters in size without significant brainstem distortion, we can safely tell the patient that we have a 5-year tumor control of about 93 to 95% and a very low chances of other disturbances. And if the patient has a serviceable hearing, and if you can make sure that your cochlear dose is controlled well, then you can probably give them about 50% chances of maintenance of that hearing. Some of the factors which people have found over a period of time is that the pre-treatment growth rate can sometimes be a predictor of tumor control. And this has been brought up by Pollock and others, where they have shown that in about 68 patients out of their 400 odd patients, they found that the growth rate was quite high, about 2.5 centimeters, 2.5 millimeters per month. And in those patients, the control rates were lower, while the control rates were upwards of 97% in more slowly growing tumors. This brings us to the question of what do we do about the patients who have reasonably preserved hearing, a small or a moderate sized tumor. And here again, I think the policy is that we usually wait and watch in these patients. But I think today it is acceptable that if the patient has in serial imaging shows that there is a rapid growth 2.5 millimeters per year or more, this patient is more likely to lose hearing early, and therefore such patients, and they have more tendency to grow fast, and therefore these kind of patients should probably be treated with either surgery or radiosurgery early. Should it be radiosurgery or surgery? I think this group has recently published a paper that in patients with ABR monitoring, they have shown that it is possible to preserve the hearing to the pre-operative levels in many patients, and therefore they are suggesting that you should probably not wait. It may be better to probably operate on these patients. On the other hand, you also have papers showing that radiosurgery may preserve the hearing, but most of the papers are showing that over long term it gets reduced further, and therefore a especially low dose gamma knife radiosurgery is recommended for such patients. So basically today, if we have a small tumor and if you have hearing preserved, we watch for growth patterns of the vestibular schwannoma. If there is no growth or slow growth below 2 millimeters per year, we can probably just do annual imaging studies. And if the tumor grows more than 2.5 millimeters per year, or if you have progressive hearing loss, then of course you would go either for radiosurgery or microsurgery, depending on your preference. The biggest problem what we feel is that the larger you allow the tumor to become, the risk of facial preservation certainly gets worse, and therefore it may be a good idea that once you have established that the tumor is growing, then better to probably operate. There is excellent selectivity and coverage, which is the beauty of the gamma knife radiosurgery. You can see that you can shape the beam quite well, you can save the surrounding structures quite well, and you can administer a growth of 11 to 13 gray very easily with giving a brainstem dose of less than 8 or 9 almost all the time. And even in moderate sized tumors, you can achieve that almost always. And I think the other predictors of success for microsurgery, there is a CSF cap in the meatus, something similar probably also applies even to radiosurgery. And if you can see the cochlea very well, and if you can give a dose of less than 5 gray to the cochlea, you have a better chance of preserving the hearing. So cochlea becomes one of the important dose limiting structures in patients with serviceable hearing. And you can see beautifully that on a T2 weighted image and on CT images, you can show the cochlea quite well, and you should be able to control the dose over there. And this is one patient we treated recently, a small tumor, and you can save the cochlear dose below 5 gray in these patients. Significance of cochlear dose, I think there are several papers on this, and though they have shown that below 4 gray, it is a definite predictor of hearing preservation. It has not been found in by all the groups equally well, and therefore people are talking about giving not getting consideration for this, but usually a 5 gray dose is maximum acceptable dose to the cochlea in patients where hearing has to be saved. The other dose limiting structure, of course, is brainstem for larger tumors, and brainstem tolerance limit, though it is about 12 gray, we usually try to keep it below 10 gray. And this is a larger tumor, which you can see, which is being treated, a heart tumor which has not been possible to remove in spite of 2 surgeries. And here we can still shape the beam so well that the brainstem does not get more than 10 gray dose at more than 1%. So basically, I think in a large acoustic schwannoma also, people have now shown that in a large series of over 80 patients or so, the tumor control of about 70% has been obtained, and it is possible to preserve the brainstem function in these patients. Dr. Shankar is going to talk about radiological changes post SRS, so I will probably not go into the details, but sometimes it can show temporary enlargement and the cystic degeneration, as Dr. Shilpa showed, and that can occasionally cause some symptomatic problems. The other things which you can see is cystic degeneration, malignant transformation very, very rarely, and local tissue scarring has been reported by some teams who have operated on such patients. So therefore, the concept in a larger tumor is probably to use a fractionated radiotherapy for tumor control in these patients. There is going to be another talk on fractionated treatment, so I am not going to go into the details, but it certainly seems that it is probably as effective in tumor control, but seems to be less effective in facial preservation and hearing preservation. So there are several series which have shown this, and though it will be a part of another talk, I will leave it over there. But this is typically what you see, that tumor goes cystic degeneration and then becomes smaller. I think the basic difference is, of course, you can do a single treatment and it is still preferred for tumors under 3 centimeters. If the tumor is about 3 centimeters, then you might consider fractionated treatment. This is what is generally believed. CyberKnife has become another new player where there is excellent tumor control, 94% plus, and the hearing preservation rate is also shown to be good, but most of these series are of 3 or 5 fractionated treatments, and facial weakness is also very, very low in these patients. And this recent meta-analysis has also shown that though there is a variation in how people treat these patients, there is usually in over 800 patients, they have shown that the margin dose around 14 gray, and if you become fractionated, it might be higher, but the hearing preservation rate as well as the facial preservation rate seems to be good with a local control. Proton beam, again, there are some attempts at SRS kind of a treatment, but usually it is fractionated and local control rates are good, but hearing preservation rates again are not very encouraging. So I think the couple of things which are probably to be specially considered are the cystic tumors. There is a widespread belief that cystic tumors are better treated by surgery, but even surgery has a higher rate of complications in cystic tumors, as has been shown by a large series from AIMS. It will take me 1 more minute. And there is a recent paper which shows that the SRS works well on cystic tumors as well. Our protocol has usually been to decompress the cyst and then probably treat these tumors. And there are different kinds of cystic tumors which have been described now, and you can probably decide the tumor treatment accordingly. Patients presenting with trigeminal neuralgia, I think surgery probably gives a better outcome in terms of trigeminal neuralgia, and there is a possibility that you can treat the tumor at a lower dose and the trigeminal root entry zone with a higher dose in such patients. Hydrocephalus developed during post-radiotherapy period can be treated independently rather than going for the tumor directly. I think what we do after the post-surgery, usually if there is a small nodule, we wait for it to see if it is growing. If it is a linear streak, it is not very commonly that it grows. So these tumors are observed, but if you have left anything more than 1 centimeter nodule, then we try to treat these tumors. Proliferative potential can be one of the directives towards using radiosurgery or not immediately. Microsurgery after failed radiosurgery is being reported. There is one report from Pollock's group where they have shown 14 cases, and recently Dr. Mishra has reported 13 cases. Microsurgery is not very difficult. I have personal experience of about 3 patients, and in these patients, we usually try to do a decompression rather than trying to go for a complete excision. So I think in conclusion, I would say that radiosurgery in vestibular schwannoma, sporadic vestibular schwannoma, is restricted to a newly diagnosed tumor. If it is less than 2.5 centimeters, in my experience, a post-op residual above 1 centimeter, and the risk of facial and trigeminal nerve deterioration is very, very small, and hearing preservation can be achieved in small tumors to a reliable extent of about 60%. Thank you.
Thank you, Dr. Dev Pujari. That was an excellent presentation, very balanced, both in terms of the surgery, the stereotactic surgery with gamma knife, and then moving on to the cyber knife series. Once we have treated these tumors, I'm sure there is a lot of radiological changes which happen, and it's important that we learn about them so that when we see patients on follow-up, we are able to distinguish between growth of the tumor and necrosis. The next speaker is our very own Dr. Dynamic, Dr. Shankar Wangipuram, and I will request him to make his presentation. Dr. Shankar, you have 15 minutes. Please go ahead.
Yeah. Hi, good evening, everyone. Let me just draw your attention that the management of acoustic schwannoma, there have been changing trends. The initial was to wait and scan policy, surgery, or radiation. These are broadly the 3 applications that one uses while combating the disease. The emphasis of the treatment is more on to preserving the quality of life. Essentially, the management decisions should factor in size of tumor, the signs and symptoms, the patient age, comorbidities, and patient preferences. The approach typically needs to be multidisciplinary, and it should incorporate neurosurgery, otolaryngology, and radiation oncology. So, if you want to summarize whatever presentation which Dr. Deo Pujari has made, as I said earlier, the goal has shifted in surgery from total resection to more towards a long-term tumor control with maximum functional preservation. Large tumors greater than 3 centimeters, undoubtedly surgery is the best option. We need to definitely do the surgery because radiation partially increases the brainstem compression and compressive ischemia of the 7th nerve due to post-treatment edema. And if there is a post-op residual, sometimes the surgeons, if they are not having neurophysiology, will intentionally leave behind areas of the tumor which is close to the patient now. So typically we tend to observe these patients. because there is a finite probability of spontaneous devascularization of remnant, which results in involution. And the second is the nodal volume. If it is more than 0.4 centimeter cube or dimension more than 1.5, that is the time when there is a greatest risk, and therefore we give adjuvant radiosurgery. And when the patient is not a surgical candidate.
Dr. Shankar, sorry to interrupt. Could you increase the volume or speak a little louder, please?
Yes, sir. If the patient is not a surgical candidate, that is the time we give SRT. For small to medium tumors, which are measuring less than 3 centimeters, typically in patients more than 60 years with significant comorbidity, small tumors, absence of symptoms, as Dr. Pujari alluded to, we observe the growth rate typically more than 2.5 millimeters. That is the time we advise for some intervention if our goal is to preserve the hearing. Regardless of the age, the window of opportunity for functional hearing preservation, you can achieve either with surgery or radiation. Both in the hands of a good neurosurgeon, the outcomes will be better. But having said that, when the hearing is more serviceable with pure tone audiometry threshold more than 50 decibels or speech discriminated score more than 50, that is the time radiosurgery is something which can be easily doable in a non-invasive fashion. Now, brainstem compression also we need to keep in mind is graded into different types, which is grade 0 when the tumor just reaches the brainstem surface, in grade 1 when there is no distortion which you see right in there, and 2 and 3 this causes a mild and a major distortion. Typically, whenever you have a lesion which is just kissing the brainstem or without any distortion, radiosurgery can be contemplated, but definitely not in this particular clinical context. Radiosurgery is an option. So it is either in grade 0 or grade 1 that we do radiosurgery, and this is the typical outcome that you see right in there. Summarizing about the observation part, schwannomas grow at an average of 2 to 4 millimeters per year, whereas less than 10% regress. It is the extrameatal tumors are more likely to grow compared to intrameatal tumors. Now, this is very important for a couple of reasons. Number one, the cellular proliferation is low when the tumor size is less. The second important thing is when the tumor actually invades the CPA, it actually gets an opportunity to grow three-dimensionally. Regardless, if the growth rates are more than 2.5 millimeters, as Dr. Pujari alluded to, we have to really resort to some kind of intervention. Now, small tumors, we always offer conservative kind of management. Now, this is very important because it gives the patient some time to think about any intervention and the side effects. If the patient wants to undergo radiosurgery, the efficacy of radiosurgery on small tumors, intracanalicular tumor radiosurgery, the outcomes are a little inferior. That's not ideally the choice for doing radiosurgery, because the smaller the tumor, the less is the proliferating cells. Having said that, there are no standardized ways of measuring tumor growth and reporting the results, and a fair comparison of radiosurgical results with natural history of acoustic neuroma is absolutely not possible. So if you look into the observation series and the radiosurgical series, the follow-up period, which has been used in majority of the observation, is mean follow-up, and unlike in radiosurgical, it is the median follow-up. So therefore, your actual projection rate is inferior when you use median follow-up. The tumor size essentially is unidimensional using the AAO-HNS guidelines for observation series, but in radiosurgical, it's more pragmatic, it's volumetric. The growth rates essentially in observation series are linear dimensions, and that is not something which is followed in radiosurgical, where we essentially look into the volumetric measurements. And lastly, when you say tumor control, the observation series is all about no growth. But here we use the Flickinger definition, where it is 1 millimeter in two directions or 2 millimeters in any one of the directions. So, as alluded by Dr. Pujari, there are many predictors for successful outcomes in radiosurgery. Number one is a young patient. The patient should have good preoperative word recognition and pure tone thresholds and speech disseminator scores. Marginal tumor dose should always be around 12 to 13 gray. Cochlear dose always less than 4 gray. Now, obviously, patients who are older, who are large, these are patients who are at risk for progressive post-treatment hearing loss. Now, having said that, you need to keep in mind the long-term outcomes of hearing preservation at 2 years, 5 years, and 10 years. In the first 2 years, it is high probability, it is between 50 to 70. You fish out any literature, you will have around 80% of outcomes, 75 to 80. And the same even with the 5 years. But it is moderate low probability at the end of 10 years. So at the end of 10th year, if you see, there will be a finite number of patients who are having a moderate low probability with radiosurgery. Now, this is something different with microsurgery, which I'll tell later on. Now, it's very important how we assess the response. You know, that's very important in the context of radiosurgery. Now, diffusion weighting images is something which is very important. This is a sensitive imaging marker. Now, this actually gives us an idea about the cellular density and the extracellular free water content. Typically, this is one of the patients with the ADC values around 1.2 into 10.3, 10 to the power of -3 millimeters per cube. So what we essentially need to incur in all the patients, typically all the patients, we should run through diffusion sequences, because that whenever you find ADC values beyond this, there is an increase in the tumor fluid component, because there the diffusion decreases, and therefore you will have more of cystic components, a lower nucleus to cytoplasm ratio, and typically the kind of Anthony B kind of tissue which is situated right in there, and that is something which will have better response to radiosurgery. So if you look into the type of tissue in acoustic schwannomas, typically they are divided into type A and type B. Type A is something which is compact and highly cellular, and type B is hypocellular. That is very. Now, the prominent feature of type B is abnormal vessel proliferation and the hemosiderin deposit. So therefore, these are the tumors which are more vulnerable for intratumoral hemorrhage and necrosis, and obviously the cyst formation. Now, this is the basic mechanism as to how the cyst actually evolves. Now, we can also look into the ADC values. As I said earlier, non-responders, the higher the ADC values, which is the apparent diffusion coefficient, the higher the ADC values is compared to what you see in responders. The using minimum ADC values of around 810 to the power of -6 currently actually classifies 90% of cases whenever we do radiosurgery. Like this was one of the patients who had ADC values which is relatively high. You can see 4 years down the line there is not good response to radiosurgery. Now, the other level of investigation which is particularly important in defining the tumor control or regression is the functional diffusion map. Now, this is very important because we need to understand the spatial heterogeneity exists within the tumor, and the FDM is a better tool for us to assess the vascularity, the cellularity, the cell membrane integrity, and delineate the regions of neoplasm. What really happens is the longitudinal DTI studies are done pre-treatment and then mutually registered with the series of MRI scans which are acquired over 2nd week, 4th week, 8th week, 12th and 24th week. They are all the warping parameters, obviously, which are used on the DTI sequences. And finally, the data is analyzed for the mean diffusivity, the fractional anisotropy, and IVDC. Typically, if you see the mean diffusivity is transiently decreased followed by increase, and this is exactly opposite to what you see with IVDC, and FA is decreased continuously during the therapy period. Sometimes, if the patient is actually allergic to the contrast, we can use Swi Sequence, and there is enough data which is published for that. Now, what you really need to understand is that early radiosurgery actually improves the hearing outcomes in much better way without compromising with the tumor controls when compared over a period of 5 years, and there is enough data which is published for it. The skull-based approaches for resection are undoubtedly eluded by Dr. Deo Pujari. I'm just trying to skip that. All I need to tell you, I'm sure Dr. Goel also will speak on this very elaborately. All I would like to tell you is this important slide, which is if you choose the modality, if the long-term hearing preservation is the goal, there is evidence right now available in a meta-analysis comparison between micro and radiosurgery that at 2 years, the outcomes are relatively good with either micro or radiosurgery. Even at 5 years, it is good. But at the end of 10th year, if you look into the long-term outcomes of the published meta-analysis literature, there is a little inferior probability for microsurgery compared to the moderately published outcomes which you see with radiosurgery. So honestly, yes, this is something which we always need to keep in mind. So why we really need to do the post-treatment imaging? We need to essentially identify the residual and recurrent tumors, assess the tumor size, response to radiotherapy, and the presence of post-therapeutic complications. Now, the biggest challenge associated with radiosurgery is interpretation of the follow-up MRI. What you see, the radiologic stability right in there is not always the best surrogate for treatment success. Now, if you look into the volumetric regression patterns, you can have a stable disease. Like this is one of the patients who had the same volume all through the course, the disease was not increasing in size. Or the disease kind of regresses is the second kind of regression pattern you see right in there. And the third one is a persistent growth. Actually, there is growth which is happening right in there. Again, all these patients who can do the diffusion weighted scans to understand the response which you find with radiosurgery. And the last one is the pseudo progression. This is very important part in the interpretation of post radiosurgery patients, because many a times we fall into the trap where we presume that the disease has actually progressed and the patient is rushed for some kind of salvage treatment. So what I'll be spending in the next 5 minutes is more onto the pseudo progression. Let me just fly you through a small example. This was a patient who had a left-sided Couche grade 3 acoustic schwannoma picked up way back in 2008. So the patient underwent surgery, and in 2009 there was a small residual that was kind of picked up in the post-op treatment. So the patient was put on observation, and during the period from 2009 to 11, there was a small interval increase. So essentially, we discussed the options with the patient and took him for radiosurgery. You can see right in there. So a marginal dose of 12 gray was kind of delivered. 2014, you can see there was a pseudo progression which has happened right in there. Probably it would have kicked in earlier, but the patient was put on a yearly scan, and you can see in the second year post radiosurgery there was an increase in the size. We just kept this patient on follow-up, doing nothing, and you can see that in next year scan, the lesion was actually decreasing in size, and 17, everything was kind of come back to normalcy. So if we look into the temporal dynamics of pseudo progression, this transient volume of increase is more common in females, and it is more common in patients who undergo prior surgical reaction, surgical resection. Now, if you look into the way, the mechanism why this happens, it happens because of acute inflammation of the surgical doses of radiation which we are shooting, and the vascular occlusion, typically common kind of radiobiology you see with surgical doses of radiation. Now, both this will result in some kind of necrosis and inflammation, and also because of vascular inclusion, there will be some kind of intratumoral hemorrhage. Now, it's very important that this transient volume increase was significantly correlated with previous surgery. I'm reiterating, and also it increases the rate of facial and trigeminal nerve toxicities. If you look into the incidence across the published literature, it ranges from 11 to 60%, with a maximal volume change ranging anywhere between 20 to 75%, and the median time of enlargement is anywhere between 6 months across the published literature. Now, there was an interesting clinical trial which has defined a volumetric change criteria of 20% to define the response to the treatment or progression. So it's very important. You know, the criteria for diagnosis of tumor control and treatment failure, typically post-SRS, what we essentially look into the volume at the end of second year. If it is larger than the initial, that is the criteria which many of the people kind of use. It's a kind of the criteria. But typically across the literature, if you go, there was an interesting paper which was published by Regis et al. You can see this patient at the third year had an increase in the size post radiosurgery. It didn't happen within 6 months as published across. And slowly this patient was kept on follow-up. At the end of 10th year, the disease has actually decreased. Similarly, yet another patient, there was a pseudo progression which has happened at 7th year, 9th year. It is increasing, and then, you know, at the end of 13 years, there was still a decrease. So it's not necessarily that pseudo progression happens only at 6 months to 12 months. It can happen at any time during the period post-treatment. So essentially, the diagnosis of failure requires a longer follow-up to distinguish between treatment failures and the so-called late responders. So if you look into the transient tumor swelling, the conventional definition is a phenomenon which occurs only at first or second MRI, which is spaced 1 year apart and followed by a decrease. But the revised definition, it includes a time frame of 3 to 4 years. So any time between 3 to 4 years, if you find an increase in size, that's the time you can actually consider for a pseudo progression. Now, I would like to draw your attention that microsurgery after radiosurgery should be performed only for worsening clinical condition and obviously not for tumor volume increase. Now, this is very important. You know, if the patient is having neurologic deterioration in any of the clinical contexts, you have to do surgery, intervene with the surgery, regardless of central necrosis you see there, the solid expansion, cystic enlargement, cyst formation. All these are kind of complications which you see. It is in the, not even complicated, the natural evolution of the disease post-radiosurgery. So therefore, it's very important that we understand the neurologic deterioration in the context properly while taking a call for some kind of salvage treatment. Now, post pseudo progression, let me just draw your attention to what really happens after surgery, radiosurgery. There will be some kind of cystic enlargement which regresses. And also it's very important, the contrast enhancement patterns actually keep varying post radiosurgery. You can see transient, there is a transient loss of contrast enhancement followed by a continuous regression with recovery of the contrast enhancement. And this is more so because of the tumor necrosis and the obvious vascular damage which you see right in there. But again, as I said, this is not predictive of clinical outcomes. The second important kind of change which you see right in there is a continuous increase in the contrast enhancement without transient loss of contrast enhancement. Now, this is very important. And the last one is there is really no change in the contrast enhancement patterns. Now, we also need to keep in mind that there is some kind of changes which happens in the adjacent areas as well. Now, there could be a hyperintensity which is situated right in there, but this again did not correlate significantly with the initial tumor volume, the peripheral dose, the maximal dose, or the history of previous surgery. So there could be some peritumoral edema. This lesion, usually if you see perilesional edema, the lesion is kind of more vascular. The chances that there will be cystic degeneration into future is very high. And again, as I said, this does not correlate with the degree of tumor adhesion and progression and the presence of arachnoid dissection place. Now, you need to keep in mind this particular complication post-radiosurgery, which is hydrocephalus. Now, please understand that hydrocephalus can also be seen in the normal vestibular schwannoma patient, but the factors which actually contribute post radiosurgery is increased age, typically with lesions more than 3 centimeters, and specifically more if this lesion has recurred post microsurgery, and those patients with NF2. Now, this happens more so because of elevated CSF protein, which alters CSF resorption. Now, we don't advise any treatment if the patient is asymptomatic, but if there is a patient is symptomatic, then yes, VP shunt is something which can be contemplated.
Dr. Shankar?
1 minute, sir. This is my last slide. This is my last slide.
Okay.
Yeah. So we can actually, this was one of the patients who had a post patient was done surgery. There was a heavy bleeding, so the neurosurgeon kind of stopped the treatment. They stopped the surgery and later on referred for radiosurgery. This was grade 4 disease. Obviously, the patient was counseled and we have done radiosurgery. Of course, this was more fractionated rather than a single fraction, and you can see even 5 fractions was delivered, and you can see a good response post radiosurgery. So to conclude things properly, what really needs to know in the context of post-treatment imaging is pseudo progression, and we have to use volumetric imaging. The peak expansion rate is seen somewhere around 6.4 months, but in 8% of patients, it can be seen up to 5 years. So baseline scan should be done at 6 months and thereupon once every year. Patient symptoms and tumor size must be considered, and giving the tumors a chance to regress before opting the patients for salvage treatment may always be worthwhile. Thanks much for your patient listening.
Thank you very much, Dr. Shankar. I think you brought out some very important points, particularly for our younger colleagues, and that is that schwannomas after treatment, you need a lot of patience. You can't say at 3 months, oh, the tumor has not regressed, therefore there is some problem. You need a lot of patience. You need to be aware of the pseudo progressions which can occur. So you brought out very important points, and I hope our postgraduates have absorbed that. It's one of the lesions where the radiation oncologist needs a lot of patience before concluding that the treatment has not been successful. So thank you very much for a very good presentation. Right, we now move on to nuances now, and I would invite Professor Atul Goel from KM Hospital, Mumbai, to talk about acoustic schwannomas, technique, indications, and results. Professor Goel.
So I will talk to all of you on my very, very dear subject, and that subject is acoustic schwannoma surgery. You see, I must warn you that basically my presentation will be based on the surgical issues, because my information about radiosurgery and other forms of radiotherapy is not as good. But I have heard and I know that radiation therapy is an effective modality of treatment for acoustic neurinoma. So I belong to KM Hospital, and those who do not know KM Hospital is an industry of patients, and my life and my work has depended more on this hospital than on my personal skills or caliber. It's a fantastic hospital, and is an absolute pleasure to work in this hospital for several years, nearing 4 decades now. And I am also attached to Lilavati Hospital. So basically what I will like to do is, I will like to give you some of my personal experiences about hearing preservation and facial nerve function in my last 100 cases. This is not last 100, actually these 100 cases are from January 2015 to September 2016, about 4 or 5 years ago when I had given this presentation. I'm going to summarize my work and summarize my thoughts about radiation treatment. See, many of the patients who come to KM Hospital come in a little bit of an advanced situation only hearing preservation is not the thing. Many of them come with very severe ataxia. Several of them come with visual problem and towards blindness. And a large number come with symptoms of trigeminal symptoms like numbness over the face and things like that. So my estimation will be when there is ataxia and there is visual deterioration, the role of radiation treatment may not be as strong. And if the person has come only with the symptom of hearing loss and no other symptom like ataxia and vision problem, maybe there is some role for radiation treatment. But I must tell you that acoustic tumor surgery is not easy. Acoustic tumor surgery for small tumors, for large tumors, for massive tumors is an important component of a neurosurgeon's life. We love to do acoustic neuronoma surgery. Just when we see the acoustic neuronoma, we start thinking about operating because that is one more beautiful kind of surgery that we like to do. That is one thing, but on the other hand, it is not at all easy. I must tell you, and you must know because I know many of the people sitting in the audience are radiation oncologists. I can tell you there are not many neurosurgeons in the world who can remove acoustic tumor completely and can save the facial nerve function. There are hardly very few neurosurgeons. And if you are going to operate on these tumors and you can create devastation with facial nerve function, and in case you are still not very efficient in doing these tumors, you can create lower cranial nerve issues, you can create various other kind of issues. And if you are going to create such issues, there is no question that surgery for acoustic neuronoma is going to be very soon neglected and avoided by the patients. So for these kind of relatively small tumors, and if the person has come with marginal symptoms of hearing deficits and all, it is a standard of care now in the world probably that many of these patients will go for radiation treatment. But I am warning you again that I am not radiation expert. I cannot give you the indications of radiation treatment. I am going to show you the surgical cases which I have done during this 1.5 year period. And all these cases belong to that group. So even this is a acoustic neuronoma. Maybe this is very well suited for radiation treatment, as Dr. Shankar was saying. These are slow growing tumors. These are benign tumors. They grow slowly over several years. And the other thing is whether it will grow or whether it will not grow, that also is an issue. So radiation treatment has come alive and has become popular because the issue is that at least you do not create devastation of facial nerve deficits. Whilst as a surgeon, I would like to even operate on these tumors, small tumors, the quality of facial nerve preservation, the incidence of facial nerve preservation is higher. So I will like to do this case, but no matter what, the deficit, the probability of facial nerve deficit remains, and you just cannot say I will not create facial nerve deficit at all. That is not the way you have to deal with this problem. There can be a deficit, and as you know, facial nerve deficit can be a devastation and can be a huge deficit for the entire life of the person. Whilst I love operation, there is no question this case needs operation and there is no other treatment. I love to do this operation, and the way we are operating like a factory in KM Hospital, my feeling is we have got a fantastic experience in doing these cases. But whether fantastic or not fantastic, the chances of facial nerve deficits remain, despite the fact that the entire operation is based and concentrated about preservation of the facial nerve. That is one I will talk about hearing a little later in the course of the lecture. But facial nerve preservation is the absolute necessity. I am not saying that if the tumor is gone and facial nerve is gone, it is a disaster. It is not like that. But facial nerve deficit is a huge deficit. On the other hand, there are, I'm repeating that there are not many neurosurgeons in the world who will be able to operate these tumors radically and completely and say, I can save the facial nerve. They are very, it is not a child's game. Large acoustic tumors can be absolutely dangerous tumors, difficult tumors. And if you create lower cranial nerve deficits, once in a while may be accepted. But if you create on a regular basis, you are not permitted to do acoustic tumor surgery. Facial nerve preservation can be an important issue, and that is one of the main issue in acoustic tumor surgery, particularly of this size. These are difficult tumors. These are not difficult for surgery. These are not easy tumors. These are dangerous tumors. These are dangers. But on the other hand, if you are able to preserve the facial nerve function and remove this tumor, that is a, almost amounting to cure, which no radiation can ever say that I will cure you. So if you are able to preserve the facial nerve and you are able to remove this tumor, that is a most acceptable and most beautiful treatment for the patient. But whether you can do it, that is the question. I'm showing you various types of tumors in this series of mine, and you can see many of my tumors are very huge and very extensive, and surgery is the only answer. If I get this tumor, I will tell you my surgical strategy will be to remove this tumor, and leave a small shell of the tumor on the facial nerve to preserve the function. I can tell you in these large tumors, if somebody says I can remove this tumor completely and I can shell out the facial nerve completely, he's absolutely making a mockery of neurosurgery. It can be possible once in a while, but in general, these large tumors, if you want to save the face of the patient and if you want to save your own face in front of the mirror when you go and watch, okay, a devastation, no facial nerve dysfunction is of course a very, very bad complication. So if I have to do, I will leave a small shell of tumor. Of course, if I say I will be conservative and I only debulk the tumor, then you do post-operative imaging, you will leave a large shell of tumor behind. So it is radicality is your mainstay as a surgeon. You cannot say I'm a conservative surgeon. You have to say I'm a radical surgeon. I want to remove it completely. But to remove it completely and create facial nerve deficit is not a complete resection. So as far as the tumors in my series, there were some solid tumors. Cystic tumors have special importance in neurosurgery. They're relatively easier to debulk, but the shell of the tumor can be difficult. Multiple necrotic parts of the tumor. This is a different kind of tumor. Vascular tumor is another kind of tumor. I will say solid tumors and vascular tumors may be more suitable for radiation kind of treatment, if at all. My experience with these tumors, you see these large tumors, I'm again repeating before I go further that if this patient comes to me, my aim of my surgery will be radical resection, and radicality is the name of is an alternative name that I like to have for myself. Radical resection and save a thin shell of over the facial nerve. Even that is not easy, and I am not saying that while saving the facial nerve, I will save the facial function in all the patients. I have demolished face in a number of cases, and neurosurgery is a big leveler. You do facial nerve preservation in 100 cases, and the most important person that comes, you will damage the face. So neurosurgery, you can never be very sure, and you can never be very certain that, yes, I can do it. Of course, if you don't have confidence, you will never be able to do it. So my strategy remains very clear that remove the bulk of the tumor and save a small bit of nerve, small bit of tumor on the facial nerve. And I am repeating that this saving of the small end of the tumor along the facial nerve in large tumors is mandatory. And if somebody says I can remove the facial tumor completely and save and make the facial nerve naked, is an absolutely mockery of neurosurgery. That is not possible. Many of these tumors are associated with cysts outside the tumor, necrosis within the tumor. You see huge tumor, necrosis in the more dangerous part of the tumor near the facial nerve. You see in the cystic tumors, the facial nerve is displaced in an uncertain location. Flow voids within the tumor are relatively rare, but if they are present, that does not mean they are extremely dangerous tumors. My surgical, I can, many of you are not surgeons, but I can tell you that I have grown with these tumors all my life. We have the largest experience probably in the world. Of course, there are some senior people in the world who may have larger than us, but our experience is absolutely phenomenal. And I have to say one sentence for neurosurgeons that no acoustic tumor surgery should take more than 1 hour. And if you are doing more than 1 hour surgery, then you are doing unnecessary coagulation within the tumor. Coagulation within the confines of the tumor is not necessary, is a waste of time. Coagulation outside the tumor is a technical mistake. You need coagulation only very limited in acoustic tumors. Acoustic tumor surgery should not take more than 1 hour, that is period. And this statement of mine will be taken, many neurosurgeons will not, take it easy. But I have shown several workshops I have conducted. I have done 6 acoustics in half a day in my workshops and on several occasions. There is no question, and I don't feel sorry to give this statement. Many of these tumors can be multiple cysts, and I believe that these are easier to operate, but the shell of the tumor, larger shell of the tumor has to be left behind, because these tumors, the facial nerve relationship is more intense in these tumors. Tumors with fluid level are more, easier to operate, but the recurrence rates are higher. And when you see fluid levels within these tumors, these are sure cases of upfront radiation may be an option in these cases. Many of these large tumors, you see, I am again repeating you, there are not many people in the world who can do these large acoustic tumor surgery safely and confidently. Everybody wants to do acoustic tumor surgery. Every neurosurgeon, you ask them, you'll say, I want to do acoustic. This is my main operation. I am very good at it. Basically, the way you do acoustic tumor surgery determines the level of a surgeon. You develop your skills with acoustic tumor. You grow better as you grow in your experience. Bilateral acoustic tumor is a different game, as we have heard. So face is an important entity. You see beautiful face. I am not saying you can have facial preservation in such beauty in all the cases, but if you are confident and if you can remove the tumor and preserve the face, there is no other treatment better than this. These are very beautiful faces. As you can imagine, they come and they are cured. They are, even if you have left a shell behind the in vicinity of the facial nerve, it does not matter. What matters is the face. What matters is the outcome. And it is not, I am not saying that I do not create devastation. This person, you can create situation where you can create mental retards, you can create suicides, you can have murders if you create such faces. But on the other hand, if the person has come with ataxia, has come with visual deficit, has come with trigeminal sensation, come with difficulty in walking, they become normal. They become completely normal except the face. So there is a role for surgery if you can have, even if you have a facial nerve deficit, if this person is able to work completely confidently in house, there is a big role. Essentially, the role of surgery is to have a beautiful smiling face, but this does not happen. And I tell you, this does not happen on a regular basis in the hands of most neurosurgeons of the world. So I had said in one of my articles, is total tumor resection and facial nerve preservation possible in large acoustic tumor? Total resection means you completely bare the nerve. This kind of total resection and facial nerve preservation is possible, but in a very small and limited number of cases. Essentially, what matters is the face. Now, what I am going to talk to you is about hearing. During the period of my experience, I have developed some special skills on preservation, not preservation, but improvement in hearing function. And I want to show you small tumors. Of course, many people say that we can preserve hearing, we can improve, not improve hearing, nobody says. And I am giving you improvement in hearing in these kind of massive tumors. And I can tell you that this hearing improvement, because I have got some special, I cannot, of course, show you too many videos in this presentation, but I can tell you there can be hearing preservation, not only hearing preservation, hearing improvement on a consistent basis in these mega tumors is possible. And this is a video, I don't think it is a good idea to show video to a non-surgical kind of audience, but maybe little bit I want to show you. You see, these are the 8 nerve fibers here, and the up is the 7th nerve, 8 nerve fibers, and 8 nerve fiber preservation is possible on a consistent basis. So let me see this, if you can hear. See, he says that. See, he says he can hear better after surgery and solidly. And I am saying it is not a one-off case. It is on a consistent basis. In these mega tumors, you can have facial nerve preservation. This is the video. I'm not going to show the complete technical situation because still I have kept it hidden. I have to, before I show it to everyone, I have to be convinced myself, and publication should be enough on the subject. But here are the 8 nerve fibers and the 7 nerve fibers, and here is the patient. See, she's talking in Marathi, but see what she's saying is she has improved in hearing and ataxia on a very strong, in a strong manner. This is another tumor, and this is the video. And here are the, it is not right to, you see, here are the 7th and 8th nerves I'm shelling off. And I have to tell you, the preservation of 8th nerve function is easier than preservation of 7th nerve. I leave some tumor behind on the 7th nerve, but not on the 8th nerve. And this is the patient, and you just listen in Marathi.
Sorry to interrupt, Professor Goel. Could you please wind up your presentation over the next 1 minute or so, sir?
Okay, now what I was saying is, these giant tumors, these large tumors, there is no way any radiosurgery or anything can be of any help here. But if you can preserve the face, and if you can get the hearing back, there is no other treatment like that. And if you can do it, that is the best. The question is whether you can do it. And I can tell you that very few people in the world can do good acoustic tumor surgery. And that is why many patients all over the world are now switching off to radiosurgery, because after surgery, if you can get a bad facial devastation and in addition other cranial nerve deficit, then nobody would like to go for those kind of treatment, particularly if the tumor is small. And if the tumor is big, there is no option but to reduce this tumor bulk at least, and to get going with life, even if you have a facial nerve weakness. And I'm not trying to say that I preserve facial nerve in all the cases. But my aim of entire operation is to preserve the face and to improve the hearing. And I have already told you that if necessary, I leave, not if necessary, in these large tumors, you have to leave a thin shell of the tumor on the facial nerve without any question. So here is this another patient. You just listen to what he's saying. So many of these tumors are large tumors. Many of these tumors are mega tumors. You must remember that small tumors do not come to me. See, Aikala means she is able to hear. And this is another case with the audiometry here. And let us see what this lady says. See, these are. Now you see, these are. So these giant tumors, these large tumors are dangerous tumors. They are benign tumors and you can give completely new life if you can remove them completely. And if it is a small tumor, I am saying even in a small tumor, you can damage the facial nerve. The question of damage of facial nerve remains even in a small tumor. So as I said, neurosurgery is a very, very nasty leveler. One day you get success and one day you create devastation. And if you create devastation, that is a bad devastation. So let us see these tumors I have shown you. These are the large tumors that belong to these patients. Let us see what they have to say.
So the patient audios are not audible.
Not audible?
No. The patient audios are not audible at all.
Okay, just let me see. Okay, now they will be.
Yeah.
Now is it audible?
Yes. Yes. Please go ahead.
Simultaneously while removing the tumor and the audio part of it, for which I could not hear at all with my right ear. I can't say that it is 100% recovered, but it is slowly coming back.
This is immediate post-operative.
मला अगोदर ऐकायला येत नव्हतं, आता ऐकायला येतं. ऑपरेशन झाल्यानंतर मला छान ऐकायला येते.
See, zero hearing and you can get hearing back. These are the best results possible. I am not saying these results are always possible, but not preserving hearing, but improvement of hearing is my new mantra. And you see this lady from a village, whether you can hear what she's saying. What she's saying, she can hear now. And not hearing, let us see what this lady has to say.
ऑपरेशनच्या अगोदर मला कमी ऐकायला होतं, आता ऑपरेशन झाल्यानंतर मला चांगलंच ऐकायला येतं.
I hope you can understand Marathi. Or
not really, sir.
और फोन के ऊपर भी बात करता हूँ, प्रॉब्लम नहीं है, दोनों कान से एक्सेस सुनाई देता है. मुझे एक कान ऑपरेशन के बाद ये कान से बराबर सुनाई दे रहा है.
See this huge tumor, and this is immediate after operation. He's just his. See, I must tell you that I am not trying to say that my facial nerve preservation will be 100%. I'm not trying to say. And I am trying to say the entire operation, I will dedicate my entire effort on the facial nerve preservation. And I am also trying to say, in my experience over several cases, I have lost my count on these tumors, but I am going to get a new article on this very soon. I have never really written on acoustic tumors, but facial nerve is in mega tumors, in giant tumors. You have to save some tumor on the facial nerve. That is my real message I have to give you. So these tumors, facial nerve is important, but hearing can be improved in these mega tumors. This is a new thing which not many neurosurgeons also know, and not many neurosurgeons I not know. Nobody knows, I can tell you. So acoustic tumor surgery, time is not a factor, but due to my special technique and special nature of my work involving several tumors to be done in a case, I have already told you that none of my tumor will take more than 1 hour. There is very minimum coagulation in the entire operation. Irrigation during the operation has to be done. Dissection in a beautiful subarachnoid plane is mandatory in these cases. So again, I am showing you this slide. Is total tumor resection and facial nerve preservation possible in large tumors? My answer is yes, it is possible in a very small number of cases. I do not like to give radiation for the residual tumor. And of course, my experience with radiation, I'm now listening more about it. So my facial nerve outcome is here. I don't want to stress too much on these things, but I have to only tell you that there can be death after these operations. There can be If there is lower cranial nerve deficit on a consistent basis, you should completely not do acoustic tumor surgery. Basically, what message I'm going to give to the radiation specialist here, that surgery on these tumors is not easy. Not many people can do it properly. And Dr. Turel is sitting here, he will, and Dr. Dev Pujari is sitting here, they will, I will like to know their opinion. How many people in the world can do good acoustic tumor surgery, saving the facial nerve on a consistent basis? That is the reason why many people are going for radiation treatment. And if you can show that radiation is an effective modality of treatment, many people will opt for radiation treatment in the whole world. Thank you very much, dear friends.
Thank you very much, sir, for that very lucid presentation. Wonderful results you have shown us, and it's very heartening to know the kind of work that you're doing. All the best in your future as well. Okay, we will now move on to AS, neurophysiological correlates, facial, vestibular and recurrent laryngeal nerve, pre-op, intra-op and post-op. May I request Dr. Sudheer Ambekar to make his presentation from Jaslok Hospital. Go ahead, sir.
Good evening, everyone. Thank you for this wonderful evening. Is my screen visible to you all?
Yes, yes.
Yeah.
Go ahead.
Okay, okay, perfect. All right. So, yeah. So, my role or my talk today is going to be about neurophysiological monitoring during vestibular schwannoma surgery. As we all know, vestibular schwannoma is a very complex tumor, as Dr. Atul Goel has described just now. There is, the tumor is in close relation to the brainstem, to the facial nerve, to the vestibulocochlear nerve, to the trigeminal nerve, lower cranial nerves, multiple cranial nerves, the brainstem, and cerebellum. So it is extremely important to preserve the function of these normal neural structures while removing the tumor. I'm going to split my talk in the following headings: modalities used in neurophysiological monitoring that are relevant to the vestibular schwannoma surgery, preoperative evaluation, intraoperative considerations such as anesthesia, the technique and management of IOM signal change, and post-operative evaluation.
Sorry to interrupt, Dr. Sudheer. Your slides are not moving. You're still stuck on the first slide.
Okay.
Now it's moving. Yeah.
Now, okay. So, all right. So, I'm going to talk about all these things right from the basics of neurophysiological monitoring to a few intraoperative considerations and post-operative evaluation. Okay. So, coming to the modalities that we use during vestibular schwannoma surgery, the first is the electromyography, followed by SSEP, MEPs in selected cases, and brainstem evoked potentials where hearing is not hearing preservation is warranted. Coming to EMG, EMG is basically depolarization of axons leading to motor unit potential recorded as a spike or a compound motor action potential. The basic technique includes either a free running EMG wherein you detect any changes in the EMG potentials without any stimulation, or a stimulated EMG wherein you stimulate a particular nerve or a neural structure and you record the potentials in the corresponding muscles. Important things to note during acoustic schwannoma and vestibular schwannoma surgery, neurotonic discharges or high frequency bursts and trains are the most important responses that can give a feedback or make us understand that we are in close proximity to the particular nerve that innervates those muscles. It may indicate nerve irritation or allow feedback to the surgeon about the presence of nerve or any surgical instrument or blood or anything in close proximity to the nerve. This is an example of bursts and trains of neurotonic discharges when the nerve is in very close relation to, in very proximity to the area of dissection. Coming to, yeah. So another example of, this is the orbicularis oculi showing baseline EMG responses. And whereas once there is any handling of the facial nerve, there is increase in the potential, either a train or bursts of potentials indicating that there is nerve handling, or the dissection is in close proximity to the nerve. EMG is indicated in preservation or monitoring cranial nerves, such as cerebropontine angle tumors or brainstem surgery. Is indicated in some spinal surgeries, such as spinal cord tumors and instrumentation. This is a basic table that shows that the cranial nerves, which innervate the respective muscles, the extraocular muscles are innervated by 3, 4, and 6, and so on. There are a number of things. Important thing to note that the frontal nerve, or the 10th inner recurrent supplies recurrent laryngeal. This is an example, again, a diagrammatic representation of the various muscles of the face that we can monitor with needle electrodes during surgery. And that translates into actual insertion of electrodes, percutaneous electrodes within these muscles during surgery, so that we can record the EMG responses. Coming to somatosensory evoked potentials, they are used to monitor ascending sensory pathways through transcutaneous stimulation of the sensory nerve. So a needle electrode stimulates the sensory nerve transcutaneously, and then you record responses from the scalp, and that indicates the intactness, or the progression of the potentials through the various pathways, sensory pathways. Usually for the upper limb SSEP, median or ulnar nerves are used, and for lower limb SSEPs, posterior tibial nerve at ankle or popliteal fossa is used. This is a diagrammatic representation of a peripheral nerve that is being sensory nerve that is being stimulated, and that travels up the tracts in the spinal cord and ultimately ends in the sensory cortex. So a lesion or a disruption of any of these at any level of the sensory system can lead to loss of somatosensory evoked potential, and can alert the surgeon about any potential neurological damage. This is another diagrammatic representation of somatosensory evoked potential. This is the posterior, this is the lower limb SEPs, and this is a diagrammatic representation of upper limb SEPs from median or ulnar nerves. And somatosensory evoked potentials are measured in terms of N and P waves, and there is an amplitude and latency that we measure usually. I'll come to the importance of amplitude and latency in a few minutes. SSEP is advantageous because it does not provoke unwanted movement of the patient during surgery, unlike that in MEP. And it is easily quantifiable, and it can help, other than the fact that it helps in protection of the neural structures in the area of surgery. It can also help in detecting pressure nerve palsy or any abnormal positioning during surgery that we can, so that we can avoid any permanent neurological damage. Coming to motor evoked potentials, specifically transcranial motor evoked potentials, because there is something called a direct cortical stimulation, or direct cortical stimulation motor evoked potential. So that is why what we are interested in during vestibular schwannoma surgery are transcranial evoked motor evoked potentials. They're used to monitor integrity of the descending corticospinal and corticobulbar tracts. This is the flow of corticospinal tracts and corticobulbar tracts, starting from the motor cortex all the way to the ultimate peripheral muscle. Another diagrammatic representation of how the motor pathways travel along the motor, along the spinal cord, and ultimately ending in the motor cortex. MEPs, basically the way we produce MEPs are we give a short train of 5 to 7 electrical pulse stimuli with high frequency, and the recording electrodes are placed in selected muscles that are deemed at risk, such as the facial muscles for the facial nerve, the masseter for the 5th nerve, trapezius for the 11th nerve, tongue muscles for the 12th nerve, thenar muscles for the upper limb, and tibialis anterior and adductor hallucis for the lower limb muscles. For the vagus nerve, we usually transcutaneous the stimulation of the recurrent laryngeal nerve can be done to detect EMG response. I'm sorry, transcutaneous recording of the MEPs. MEPs can be, as we had discussed earlier, MEPs can be done by transcranial stimulation, direct cortical stimulation, or in spinal epidural space. But for us, during vestibular schwannoma surgery, transcranial stimulation is the modality that we use in all cases. Again, the utility of MEPs and SSEPs is not extremely clear in all patients with vestibular schwannoma surgery. In our institution, since we routinely do EMGs for all vestibular schwannoma patients, we also, as an adjunct, monitor MEPs and SSEPs, but that's a luxury that we have. Usually, typically, MEPs and SSEPs are more useful when there is a large tumor or when there is severe brainstem distortion, or we expect that the dissection plane between the tumor and the brainstem may not be a good one. So that is where MEPs and SSEPs are useful. The disadvantages of MEPs is that they are highly vulnerable to inhalation agents, and that's why total intravenous anesthesia is recommended. They are affected by muscle relaxants and can be performed only intermittently, unlike SSEPs, which can be performed continuously. Coming to brainstem auditory evoked potentials, these are small electrical potentials generated in response to acoustic stimuli, and they're used to monitor the cochlear nerve, basically, not the vestibular, the cochlear nerve and brainstem function. Acoustic stimulus is delivered by stimulus at the ear canal, and the response is recorded by electrode placed at the mastoid or ear lobe. This is the auditory pathway starting right from the cochlea all the way to the auditory radiation and auditory cortex. Depending on where the lesion is, or depending on the site of the auditory pathway, it is represented by a respective waveform in the brainstem evoked potential. It is important to note that for us, for vestibular schwannoma patients, the cisternal component of the vestibulocochlear nerve is at risk, and that is usually indicated by wave 2 to wave 5 delay, latency, and the amplitude. This is another example in an actual patient where we have placed a stimulus electrode is in the ear canal, and then all the facial muscles have been mapped. They have been electrodes have been placed in the facial muscles. Coming to preoperative evaluation, clinical examination is the cornerstone, and of course, in the current pandemic, clinical examination may not be, may not be done completely. But documenting cranial nerve palsy, hearing loss, and long track signs is very, very extremely important. Pure tone audiometry and speech audiometry do give us a indication about the extent of hearing loss. Brainstem auditory evoked potential, if there is potential for hearing preservation, yes, auditory brainstem evoked potentials need to be done prior to the surgery so that we have a baseline that we can compare with during surgery. Indirect laryngoscopy is an optional investigation if there is doubt that there is already lower cranial nerve palsy prior to surgery. Indirect laryngoscopy may be done to document loss of function. Baseline SSEP and facial EMGs may be done so that we can compare them with the responses we get during surgery. This is an example of an audiogram, typical audiogram of a patient with vestibular schwannoma, high frequency hearing loss, and no airborne gap. These are the two things that we need to look for in sensory neural hearing loss: high frequency hearing loss and no airborne gap. And in speech audiometry, there is a selective, loss of speech, increase in the speech reception threshold compared to that on the normal side. coming to the next slide, this is an example of a BERA of a brainstem evoked potential in a patient with vestibular schwannoma. This is the normal side and this is an abnormal side. It shows that there is decrease in the amplitude and increase in the latency of the brainstem evoked potentials, indicating that there is already some significant amount of hearing loss. Coming to intraoperative considerations during vestibular schwannoma surgery, the many anesthetic agents produce dose-dependent suppression of evoked potential. It is extremely important to have a neuroanesthesiologist who understands how to administer anesthesia for neurophysiological monitoring. Anesthesia should provide a stable physiological milieu so that we can facilitate meaningful interpretation of the signal changes that can guide accurate, surgical strategy. If there is any, if the anesthesia does not help us have interpret the responses we get during surgery, then the very the very purpose of having neurophysiological monitoring is defeated. We should be aware that there are potential non-surgical causes of neural injury that need to be considered during vestibular schwannoma surgery. Typically, we avoid using muscle relaxants if planning for EMG or motor evoked potential. This is the table that shows that how the various anesthetic agents influence somatosensory evoked potentials and motor evoked potentials during surgery. The two important drugs that need to be kept in mind are propofol and opioids, such as Dexmed, which do not change any potential, or which do not relatively are extremely safe to use in a patient who is undergoing neurophysiological monitoring during surgery. At our institution, since we do not have ramifentanil, which is a very short-acting agent, we do not have ramifentanil in India. At our institution, we follow what is called a balanced anesthesia. It's not a total intravenous anesthesia, but it's a balanced anesthesia wherein propofol, fentanyl, and Dexmed are used as maintenance agents after induction, along with a very low dose inhalational agent of less than 0.5 max, and no muscle relaxant after induction. What are the physiological parameters that can affect our intraoperative responses? So it's not that the surgeon or the surgery itself always causes any loss of potential. There are a number of physiological parameters which can affect the neurophysiological responses during surgery. Hypoxia, reduction in the perfusion pressure, hyperventilation, hypocapnia, and vasoconstriction, hypoxemia, patient positioning. There are a number of such factors that need to be considered. So when we have an alarm or when we have a drop in the potential, it's not that always it is because of the surgery. We need to keep all these things in mind and rule out one thing at one factor at a time and draw interpretation. What are the techniques used in vestibular schwannoma surgery? Free running EMG is used during initial decompression and decompression of the tumor. When we are actually around the capsule of the tumor, then triggered EMG may be used with a monopolar probe or a suction stimulator to identify the facial location of the facial nerve and preserve the facial nerve. Somatosensory evoked potentials and motor evoked potentials, as I had discussed, are optional and are recommended to use only in severe cases where there is severe brainstem distortion or we expect that there is any difficulty in the plane with the brainstem. Brainstem auditory evoked potentials can be used to monitor hearing in patients with serviceable hearing loss and where hearing preservation is contemplated. Management of intraoperative monitoring signals. What are the alert criteria for a surgeon during vestibular schwannoma surgery? In EMG, neurotonic, I'm sorry for the spelling mistake, neurotonic potential, such as loss of EMG response upon nerve stimulation or strain or bursts of high potentials is the response that that will help us understand that there is the dissection is going on in close proximity to the nerve and that we need to be careful. Somatosensory evoked potential decrease in the amplitude of more than 50% or increase in latency of more than 10% from the baseline. Motor evoked potentials amplitude decreasement more than 50% from the baseline, and brainstem evoked potentials more than 50% or permanent loss of wave 5 during surgery. This is the reason why we need to have a good pre-operative baseline so that we can compare the responses during surgery with the baseline. If we do not have a baseline, then the interpretation of these responses is going to be extremely difficult for the surgeon. And an example of a burst response that we get on direct stimulation of the nerve. This is an example of a train response we get when the nerve is being stretched because of mechanical stimulation while dissecting the tumor. So when we find that there is a loss or there is a decrease in the neurological response or neurophysiological response during surgery, there's a checklist of various things that we need to keep in mind that need to be eliminated and that need to be sorted out. So at the neurosurgeon's level, we need to evaluate the menu of the surgical retraction, whether there is any blood.
Sorry to interrupt, Dr. Sudheer. Could you kindly wind up your presentation in the next minute or so?
I'll be done. Sure, I'll be done. So in the post-operative evaluation, we just have to monitor clinically. Facial EMG and brainstem evoked potentials may be done periodically depending on the outcome. To conclude, this is the evidence-based guidelines from Congress of Neurological Surgeons. Although the evidence is not robust, but it's only level 3 evidence that it is recommended to use intraoperative facial nerve monitoring. Can be used to accurately predict facial nerve and long-term facial nerve outcome. Presence of favorable testing reliably portends a good facial long-term facial nerve outcome, and but the important thing to note is that the absence of favorable testing in the setting of an anatomically intact nerve does not reliably predict poor outcomes. So suppose you have preserved the nerve anatomically, but the responses are lost, it does not mean that the patient will end up with permanent facial nerve palsy. And that's it. I think ultimately it is not a one-person effort. It is a team effort, and I thank Dr. Dev Pujari, Dr. Rajni, and Purnima Shah, and our residents and neurotechnologists for their help in the surgery. Thank you.
Thank you very much, Dr. Sudheer. It was very nice to see neurophysiological monitoring of this complex surgery. And I'm sure the surgeons appreciate it a lot more than anybody else. The help that you're able to give the surgeons. And I'm sure the outcomes are also dependent to a fair extent on your guidance before, during, and after surgery. Thank you very much for that presentation. I'm glad to say that Professor Goel is back with us. Sir, we lost you for some time. We would like to have you conclude your presentation in about 5 minutes or so, if you can, sir.
Okay.
We now come to the last presentation of the day, management of surgical complications and failures of acoustic schwannoma surgery by Professor K.K. Thurai from the Bombay Hospital in Mumbai. Professor Thurai, please.
Full screen.
Thank you very much. Am I audible?
Yes, sir,
please go ahead.
All right, okay. Thank you very much, Dr. Shankar and Dr. Kelara, for this wonderful arrangements that you've made for this very interesting subject, which is also subject close to my heart. And you had some great talks before me. I'll just add a few repetitions. Vestibular schwannoma is a benign tumor in a malignant location. And you can understand why I say malignant location, because, where is my cursor not moving? Because we can see the CP angle on the right hand side, and we have the whole CP angle exposed with the superior cerebral artery at the top. The acoustic nerve, why is my cursor not there?
Professor Thurai, your slides are not moving. Professor Thurai, your slides are not moving.
I'm not yet moved. This is the first slide of the CP angle anatomy. Can you see?
No, just the title slide is on, sir.
Okay. All right. This one is there.
No, it is still on the title. No.
All right. 1 second. We'll try and readjust something. Can you keep it like this one?
Yes. That's
is
fine.
It okay
Please
now?
go ahead. Yes, sir.
All right.
Please go ahead.
So that's the CP angle. And why I said a benign tumor in a malignant location, because look at the number of very important eloquent structures. That's our 7th and the 8th nerve complex, the ICA artery, anterior inferior cerebellar, 9th, 10th, 11 nerves, all concerning with the palatal movement, pharyngeal movement, and the swallowing movement, and the vocal cords. The trigeminal is over here. So when this tumor, this is a canal. When the tumor grows and starts coming out, mushrooming, it starts growing out over here into the cistern. That's why it's called a cisternal component. And then it grows and grows and grows into the brainstem. So I call it a malignant location because of the numerous nerves from 5th to 12th. There's progressive improvement, of course, because of the advent of microsurgery, intraoperative monitoring you just heard about, imaging innovations you heard Shilpa, intensive care, and progress in radiosurgery, which also we heard. So surgical aims are the same. I've shown you a picture where you can see a small baby bear, father bear, mother bear. The small acoustic tumor in the meatus, large tumor compressing the brainstem, grade 4, and a medium-sized tumor over here. Aim of all is the same: no mortality, complete tumor excision, no recurrence, preservation of facial function, preservation of hearing, no neurological morbidity of none, no cranial nerve involvement, and no operative morbidity. All surgical aims, isn't it? But that is what we are expected to do. Over here, with a small meatus, with a small acoustic tumor, it's a matter of your hearing. Here it's a matter of function, including the face. And here is a question of life. These large tumors are life-threatening. So, why am I not moving forward? Well, I must first of all pay tribute to the professor with whom I trained in the 80s, and we still remain very good friends, Majid Sami in Hanover in Germany, which is the mecca of acoustic neuroma surgery in the world. Surgical outcome depends on, since I'm going to talk about management, I'm first going to talk about avoidance, how to avoid. And the principal factors of surgical outcome depends on preoperative deficits the patient comes with and the size of the tumor. Smaller the tumor, better is the outcome. And the factors during surgery are tumor vascularity and the arachnoid plane. I have to go back to this every time. 10 remarks of vestibular schwannoma surgery which were made by Professor Kobayashi. Very interesting comments. Haste makes waste. Go quick when you have to do intratumoral bulking, but slow when you are detaching the cranial nerves. Believe and doubt. No touch, no traction. Fear and fear not. Remember facial nerve always. Debulk first and see the nerves. Avoid blood staining of nerves. Respect the arachnoid, respect the arachnoid, respect the arachnoid. And retreat at an unusual difficulty. You want to save the patient's life. So these are beautiful remarks which are very useful. So the clinical presentation is based, so our surgical outcome is based on the clinical presentation, as I said earlier. Cranial neuropathy, brainstem compression, hydrocephalus, and tonsillar herniation. So we have this microsurgery for these tumors is general principles in approach and debulking, general problems and challenges. And I'll try and cover all of these. In our imaging, we must try and get nowadays this Dti imaging, because here it reliably predicts the position of the facial nerve, which is the central point of our surgical enterprise. And this has also been published by a paper from AIMS. And this is the appearance of the facial nerve in the scan, and this guides you during the operation. And this is this is the procedure that we are adopting. So that's our neuroimaging, neuronavigation. We have neuronavigation, and then we have our neuromonitoring, and then we have all these leads attached over here, and that's the patient's position. Patient's position can be semi-sitting. Many surgeons prefer that. There are some distinct advantages of that. Some people prefer half and half position. Again, there are some advantages of that as well. And sometimes lying down, it can be either supine or lateral. But you must remember, though semi-sitting is an advantageous position because of the lax brain and minimum or no coagulation, and the blood drains away, two-hand dissection technique, very easy. So you can do a very fast surgery with better preservation. But there are distinct disadvantages of air embolism, and it's not really very suitable for elderly and cardiac patients. And you also need retraction to lift up the brain when you are doing in a sitting position. You need to have transesophageal echocardiography. So avoiding air embolism, this is the correct position, feet above the level of the neck, central vein excess, hemostasis. And when this happens, you must have compression of the neck veins, aspiration of air, avoid hypotension. All this is very important, and this can only be done by a good anesthetic protocol. So we have transesophageal Doppler, capnometry, central venous line, and PEEP. So I prefer a lying position. I do sitting position in earlier years. I always did sitting position, then I changed over to this. Then I'm again changing into sitting position in some given cases, especially large tumors. So junction of iniomeatal line. So this is the point where we can identify the transverse sigmoid junction. This is anatomically very important point because that's the boundary of the posterior fossa. That's the sigmoid sinus, that's the transverse sinus, and that is the CP angle. And that's the point where we have to go. In order to know this junction, we can just put your finger or thumb behind and above the mastoid, and you'll feel a small dimple. You can do that even whilst you are listening to me. And that dimple is the point of transverse sigmoid junction. So this is a skin incision and the craniotomy. And so that is the burr place between the transverse and sigmoid sinuses. The bone waxing is to be done very thoroughly so that there is no fluid going through, no CSF going through the bone openings. So wax in and wax out when you're doing this. And here we have the complication during exposure. Bleeding from emissary veins, from dural sinuses, and there can be air embolism if you are having a sitting position. It's possible. So I'll just show you how this. So you can see the bone flap is being done, raised, and there you get profuse bleeding from the sinus. You must immediately get your suction right onto the point and get quickly some Surgicel, some fibrilla, and put it inside and block the sinus, put some cotton patty and block it. Otherwise, you can have a lot of blood loss, and at the same time you can have air embolism because of the negative pressure of the veins. So we have now a craniotomy being done over here, and when the craniotomy is done, we start from that burr hole. We make a quick, nice flap. You can do a craniectomy or you can do a craniotomy. It's about 2 to 3 centimeters. The dura is open either in a T-like fashion, as I've shown you over here, or it can be along the sinuses, cut along the edges of the sinus as you are seeing now over here. Then comes the brain retraction. Be very gentle and patient with the cerebellum. Now, the way I am showing you the brain retraction here is for a trigeminal neuralgia, where it is right on the top of the tentorium, right on top of the CP angle, where you retract from above downwards. But that is not the way we do it for acoustic neuroma. For acoustic neuroma, the correct way is to go from below upwards because the tumor is lying at the bottom. So you lift up the cerebellum with a broad blade retractor, and here you see already the lower cranial nerves. So the goal of acoustic neuroma surgery is preservation of cranial nerves. We must remember this. Tumor removal is merely a byproduct. Our eyes and ears and eyes and everything is on preservation of cranial nerves. And that's extremely important. Extra-arachnoid dissection, therefore, is the key to the surgical technique. There's always an arachnoid plane between tumor and seventh nerve. This arachnoid plane is maintained even in the internal acoustic meatus. The dissection plane should never transgress the arachnoid, and this will automatically result in the preservation of the facial nerve. So the technique is tumor debulking. As soon as you come onto the arachnoid, you open the arachnoid over the surface of the tumor and start debulking the tumor, except when the tumor is extremely small. So you start centrifugal debulking, and then you shrink the tumor from all sides. So I do a major debulking first, and then do a finer dissection closer to the nerves, as I can show you over here. So here, you see the brain spatula retracting, and now I'm already inside the tumor. I'm using a CUSA, which is an ultrasound aspirator, to reduce the tumor bulk from within and quickly go down and just leave a shelf of tumor at the capsule of the tumor, so that I don't get into the outside the arachnoid. So when you are doing major tumor debulking, you must be careful when you are using the CUSA so that you don't perforate the tumor capsule and the arachnoid layer. So leave a shelf of tumor capsule always behind, and then when you come there, the last bit of the tumor, and you can see the facial nerve right over there. That's the facial nerve, beautifully preserved. And then you see the brainstem veins. As you see the last bit of the arachnoid being lifted up, here there is practically no arachnoid along the brainstem. You can see the brainstem looking so red and blue because the arachnoid is completely thinned out. And here you have a brainstem vein, carefully preserved. The brain is pulsating very well, and that's how the tumor is removed without damaging 7-10-D8 nerves. The general problems are those of displacement, compression, and adhesion of vessels, brainstem, and the cranial nerves. And you need to know the anatomy of the blood vessels with regard to the tumor. And I will not waste my time doing that because that's not your area of interest. Staying within the tumor arachnoid, as I again said, holds the key. And see this, the arachnoid has been preserved. And here we are dissecting the tumor from the anterior inferior cerebral artery. This anterior cerebral artery supplies perforators to the brainstem and supplies small little twigs to the tumor. So you catch hold of those twigs only on the surface of the tumor and peel out the other perforators. Those perforators have no business to be coagulated. They are going to the brainstem, and when you coagulate them, you damage the brainstem. So you can see how gently I'm holding it and teasing them out, and only what is entering the brainstem on the tumor, only that. So see how easily it peels off because we are inside the arachnoid and not touching anything else. Sorry, I just missed one slide. So now there's another case where the brain is, the cerebellum is gently retracted, and you come to the tumor, and the very first thing you see is this huge artery, internal auditory artery. That's an artery which supplies the 7th and 8th. So my tumor is lying all behind it, and that's the real problem of keeping this tumor artery intact and then still removing the tumor completely. If I damage this artery, because it's coming in my way, if I damage this artery, I'm going to cause a problem. So at the end, when I've already preserved all the structures, you can imagine the basilar artery with the perforators in the brainstem. And here you have, if a brainstem perforator is taken away, then this is the infarct which you are seeing. And that's the infarct which you are seeing on the scan. So preservation of veins equally important. Petrosal vein is the one which is sitting right on top of the tumor. It should be treated with great respect, and do not sacrifice it unless you're not able to really spare it. And here there is an injury to one of the posterior fossa veins called the pontocerebellar vein. This injury has resulted in this cerebellar edema, and this edema has resulted in very massive brain swelling, and which means that you may have to stop your operation in order to save the patient's life, remove more of the bone, and I'm going to come back to that very soon. So that's one of the complications that can happen. So coming back to the brainstem veins, preserve all the veins, preserve the petrosal vein, preserve the brainstem veins. Veins are the outflow of the blood supply. And if you coagulate them, then there's going to be a turgidity of the structures. And therefore you cannot coagulate any vein. One of the nice ways, this is a tumor which is compressing the brainstem. And one of the nice ways of knowing whether there is an arachnoid between the brain tumor and the brainstem is by this wetness. This is wet brainstem. And when you see this wetness, you must understand that there is hardly any layer of arachnoid between the tumor and the brainstem. See the fourth ventricle is completely squeezed and narrowed. There's a little bit of hydrocephalus already there. So this is the operation now. The video is going on. We have lifted the cerebellum from below. We have cut the dura already from below at the bottom to allow the CSF to come out. Then we complete the dural incision all around semicircular C-shape. Get into the tumor surface and then through it internal debulking using the CUSA, and then hold the tumor capsule and deliver it from medial to lateral. And having delivered and made some space, now I can open the canal. Drill open the canal. Tumor always starts inside a canal and then it comes out. So get into the canal, start debulking the tumor from inside the canal. Again go out, go again medially. You can see how the tumor can be peeled off with 2 hands. We require an assistant to do the irrigation, and with my 2 hands I am separating. And now here you are seeing beautifully the brainstem, the 7th and the 8th over here. This is the tumor debulking. That's the 7th and the 8th. That's the brainstem. There is the cerebellum. Complete relaxation of a very large tumor. Complete preservation. But remember, these large brain tumor, the vestibular schwannomas are densely adherent to the brainstem, and we can have very serious consequences if you do not maintain the arachnoid layer over there. So that is what happens. You have a pontine infarct. So once again showing you the brainstem, how badly damaged it is. This acoustic tumor is just being lifted off. The last part of it, everything looks very magnified because I'm operating in a circle of 2 centimeters. So even a small little thing looks very large. I operate on a very high magnification, and that's the brainstem vein which is preserved. The next point that I'm talking about is drilling the acoustic canal. As I told you earlier, the tumor arises from inside the canal and comes out like a mushroom. So you have to drill the dura, strip the dura of the petrous bone, and then drill the canal. Usually about 10 millimeters of drilling is required from medial to lateral. Go right into the petrous bone and start getting the tumor out from inside the canal. First of all, you will see the tumor. If you are lucky, you will see the cochlear nerve. And of course, the facial nerve is buried down deep inside, underneath the vestibular fascicles. So tumor arises from the vestibular fascicle. That's why it's called vestibular schwannoma. It very rarely arises from the cochlear, and it almost never arises from the facial. Otherwise, it's called a facial neuroma. So this is an acoustic neuroma or vestibular schwannoma. And then, how do you know where is this canal? This is the hole. Now, this is a line which has been described by my friend in Marcos Tatajiba in Tübingen, and he talks about this Tübingen line. They call it a Tübingen line, and that is a series of neural folds which come and suddenly stop over here on the petrous bone. With a very large tumor, sometimes the meatus is completely obscured, and you don't know where this is. But if you follow these neural folds, you will know this is the meatus, and that is what is seen over here. And that is exactly a Tübingen line in the anatomical specimen. So that's where the neural folds end.
Sorry to interrupt, Professor Thurel. Yes. Sorry to interrupt. Could you kindly wind up your presentation in the next 2 minutes, sir?
I don't know if I can do it, but I'll try. So another important point, there are very many important surgical points. I don't know if you don't have surgeons, then of course it's pointless talking about it. So we have all these very important nuances. There's a jugular bulb, which is very human, and when I'm drilling the canal at the bottom over here, I may enter into the jugular bulb, and this has to be anticipated. Now I know about this, but you can see this, the jugular bulb has just given way. So I have to immediately occlude it, block it, and then continue with my surgery. That's the internal auditory artery I showed you earlier. And there are another example of jugular bulb almost bulging into the canal. All right, and then we have an intrameatal schwannoma, here also jugular bulb coming right into the canal. Management of 7th and 8th, this is the paramount part of the operation, identification and dissection. You must know that the 7th nerve lies caudal, actually inferior, the 8th nerve origin, and it goes anterior, and then it goes and crosses it, and it goes lateral to medial, and preservation of facial nerve is extremely important, as everybody else has said. So here you are, I'm opening the canal, and you can see this, I'm opening the dura in the canal, entering into the canal, the tumor is embedding completely inside the canal, and now the tumor is being delivered with 2 hands. 2 hands are working, an assistant is irrigating and sucking. And there you are, with my 2 hands, I'm mobilizing the tumor fascicles, which are from the vestibular nerve. The cochlear nerve is intact, lie down, and below that you will see the facial nerve as a white glistening structure, which is to be preserved. The anatomy of the facial nerve inside the canal never changes. But once it starts coming out of the meatus, which I'll show you very shortly, when it starts coming out of the meatus, you can see it's coming out of the meatus over here. Here the anatomy starts changing. So this is, I'm peeling the tumor now out, and this is the point 5 millimeters outside porus acousticus where I must stop. That's the point of maximum adhesion of the tumor with the facial nerve. And this point I have to stop and then come from medial to lateral and preserve all this facial nerve. That is a trick of preserving the facial nerve. But your DT, I can tell you where your facial nerve is. This is what we have found during our surgical procedures. And 7th nerve may be so thin that it just looks like arachnoid when it's severely compressed. And this has to be located by nerve stimulator or by electrophysiology. And then it can still be paretic despite anatomic continuity because of neuropraxia or interruption of blood supply or traction or thermal injury or overstimulation and so on. Many years ago, 70, 80 years ago, Dandy, who was one of the pioneers, said facial paralysis is a small price to pay for the cure of an acoustic neuroma. Today, people will not accept it. Today, we have got microscope, we have got so many techniques, so many technologies, but we still have facial nerve dysfunction after acoustic tumor surgery, and it's a debilitating and psychologically devastating. This lady is lucky, she's completely all right. This gentleman has got a grade 2 paralysis. You can see all these pictures are on the right side. This is a little more paralysis. This is grade 4 weakness, and this is complete interruption of the facial nerve with the eye becoming completely affected. So you can have varying grades, HB grades, house-filled Blackman grades, house Blackman grades, total removal, grass total removal, near total removal, subtotal removal. These are the extents of removal. Why is it important to have total resection? We always believe, I have been taught by Professor Sami, that you must try and totally remove as far as possible. Leave very little tumor behind. For this, you require to develop your technique. You require to be patient, you require to be gentle. But there will be times when very large tumors, facial dysfunction is much larger in patients who are more than 3 centimeters. According to this article by Sana, 6-fold greater in patients with smaller tumors. And this tumor, this facial nerve looks like a grayish, glistening tubular structure. So I'll show you an example where a small part of the tumor has to be left, as Dr. Goel said, attached to the 7th nerve when it is very strongly adherent, because its fast removal of the last fragment can damage the nerve. Here's a beautiful girl. She's a model and a dancer. Presenting with such a large tumor. She only presented with this tumor when she stopped missing her steps during dancing. And can you imagine the size of the tumor? It's almost going to the opposite side. And here she has a normal face, she has normal speech, she's a lovely girl. And I have the obligation to preserve her. That's a very tall order. So I did the operation, I tried to remove everything, but I had to finally leave behind a small, and this is the post-operative appearance. The face is very slightly disfigured, as you can see, and she's got no ataxia, she is walking very well, she's perfectly balanced, she's got back to bottling and dancing, and a small little bit of the tumor attached to the facial nerve, which is kept under observation. And this was operated by me some 20 years ago. There are several such cases. This is a lady who is the wife of a Saudi diplomat who had a very large tumor, and she had a wonderful tumor removal, and this is the pace after tumor removal. I won't show you the videos because there is no time. And we operated on this man. I won't show you the video, but I can show you immediate post-operative. Now you see the immediate post-operative over here. He's got, can you see the weakness on the left side? Mild facial weakness. My eye closure weakness is not perfectly normal face, but I know I preserved the face completely. So when he comes to me for a follow-up, subsequent follow-up, you see this? Subsequent follow-up is normal. He has got a very nice face, very good closure, eye closure, and he has no complaints about his facial nerve. Another gentleman who has a very large tumor again, with so many neurological symptoms.
Professor Durrell, sorry to interrupt you again. Could you please wind up your presentation?
All right. I will wind up. So this last message is that sometimes there may be no recovery of the facial nerve for several months. Don't give up. If you preserve the anatomical face, then you continue observing for 1 year, and you will see that patient's face is pretty good. So I have only covered a part of the presentation, and if you have got any time left afterwards, I can continue with it. Or if you've got any questions, I'll be able to answer with the help of my remaining slides. So I thank you very much for being so patient with me. Thank you.
Thank you very much. Thank you very much, Professor.
Thank you.
It was a wonderful presentation of surgical skills and what you can achieve. May God bless you with all your work, sir. So far, this webinar has unfortunately been very highly surgical oriented. We had one good speaker to put up the radiation oncology perspective, but unfortunately he was not able to join us till now. But I'm told now that Professor Koushik Bhattacharya is able to join us, and I would request him to speak on stereotactic radiotherapy for AS, indications, techniques, and results. So let's see what the radiation oncologist can do for this tumor. Professor Koushik, please.
Yeah, thank you very much. And I am ever so lucky that I finally managed to join in, because I was kind of thinking that I will not be able to make it. I'm switching off the video because it takes off unnecessary bandwidth, and I'm not particularly handsome, so you will not miss my face. So here we are. I'm not a professor, not yet, but thank you, doctor. And I am particularly enthralled about the fact that I can see on the board among the surgeons, many of the people whom I used to look up to when I was a registrar in TMH 20 years back. And I'm so proud to having this opportunity to share the space with them, Professor Goel and Dr. Dev Pujari and everyone. I knew them as a registrar, and now they're sharing space with them. Now, my presentation is completely scientific. I don't have any photos of beautiful models or dancers. And also, I thank Dr. Dev Pujari and Dr. Shilpa for making my job, halfway done. As you will see in the course of my discussion, that the radiation approach is a continuum which starts from the case selections. It depends on certain things, and as you see, as I was telling you, that the whole gamut of fractionated radiosurgery, single fraction, multiple fractions, or extended over a few weeks is a continuum, and the evidence for that is somewhat sketchy. And I will go and take you through that. But the learning objective of a student who is attending this seminar right now will be as follows: that you should be able to select a case, you should be able to identify and contour the lesions, contour the OIRs, planning and plan evaluation, which has been extremely dealt with by Dr. Dev Pujari, so I will not go deep into it. And because there's a lot of similarity between how you do for a single fraction on a gamma knife versus what you do on a multi-bit fraction, and that is a overlap, so I will not repeat that. And when you decide which patient goes for SRS, which patient goes for SRT, what sort of outcomes are there in terms of results and toxicity, I have no conflict of interest to declare. You know that the treatment options are observation, surgery, stereotactic radiosurgery to radiotherapy. No randomized trial or level 1 evidence. So there are two things. One thing is the patient preference. Sometimes patients say that I don't want a surgery and I want a radiation. If the results are equivalent, you have to choose them. And most importantly, an available expertise. So therefore, a neuro-oncology team is very, very vital. And we have been doing it in my institute for now 13 years. All cases of acoustic neuroma must be dealt with by both neuro-radiation oncology team, the surgeons and the radiation oncology team together, and the radiologist who is to be there. And right now, all my neurosurgical residents are also logged in because it is equally important for both. The things that determine are age, size, serviceable hearing recurrence. And for the understanding of the definitions, SRS is a single fraction. Fractionated stereotactic radiotherapy, as per the insurance company's definition, is between 3 or 5 fractions. And SRT is more than 5 fractions, and we have used up to 27 fractions in certain cases. So these are the common things that we'll remember and proceed on them. Q-stage, everyone knows the reason that I'm putting the slide here is because I want to understand that most of the patients who will go for extended fractionated radiation will be in the stage 3 or stage 4. Because the smaller ones are best dealt with either with surgery or with a single fraction radiosurgery. All the patients who are taking up for SRT, fractionated SRT, should be having a good serviceable hearing. If there is no good serviceable hearing, because one of the things that are sold on which this whole FSRT is sold, that the serviceable hearing preservation is good. And if you don't have a good serviceable hearing preservation already existing, there is no point going through this entire path of long distance of traveling. This has been dealt with very thoroughly. Just to remind you that this is the location of the facial nerve, and this is the location of the cochlear nerve in relation to the tumor. And this is something that is going to come up in the radiology again and again. And radiology has been extensively dealt with the first lecture, wonderful, and I learned a lot. You have to do a CT plane and contrast, you could do a MRI T1 plane and contrast, MRI T2, and MRI T2 contrast, which is otherwise known as the CIS protocol, or the Fiesta protocol, which is possibly the most important protocol. That said, I personally feel that the importance of siesta is kind of overemphasized in treating of SRS, and I will tell you why. The things that you look out for is erosion and widening of the internal auditory meatus. On a plain CT, on a contrast CT, you see irregular enhancement and cystic components, as you see here. I will jump through them because this has been discussed before. On a plain CT, you will have irregular hypointensity and cystic enhancement when you have a given contrast. Reason you do the cyst is because you can see the nerves within the internal auditory canal. That is the main primary reason for doing a cyst. And the T2 has got the first pinnacle for the cochlear visualization. Now, this is a classic case which can be considered for a fractionated stereotactic radiotherapy or a long 25 fractions or 30 fractions. Because this is large in size, this is a COS 4, it has got compression of the midbrain, it has got extensive extension into the internal auditory meatus and internal auditory canal. The classic things are enhancing, ice cream cone appearance, there's a CSF cleft telling that it's extra parenchymal or extra axial, you have cystic or necrotic changes, and you have compression of the midbrain. This is the classic kind of case which we'll think of using for fractionation. And the other thing that you look for fractionation in patients who have extensive intracanalicular extension. The reason for that is that you may be able to have a little bit higher visual hearing preservation, because the postulation is that if you don't give a high dose per fraction that goes to the either to the nerves or the cochlea, your hearing preservation may be better. Now, this is a postulate which has ultimately promoted people to do a lot of trials, not I will say trials, but a lot of phase 1 or phase 2s. But as we examine the evidence down the line, I will show you that it doesn't really necessarily bear out that way. This is the relationship of the facial nerve, the cochlear nerve, and the superior and the inferior vestibular nerve inside the internal auditory meatus. In a good imaging with a 3 Tesla CIESS, in a coronal cut, you will be able to visualize this. But that said, for a radiation oncologist, while you should know where it is and where they are and contour them if possible, it is not necessary that you do it, because either way, the tolerance of these nerves at this point of time, if you're using 12 or 13 gray of radiation, the tolerance of these nerves is way more than that. And you don't really see that amount of facial or vestibular nerve injury as you used to see in the days when you used to give 18 gray or 20 gray, and definitely not the kind of injuries that you will be seeing with surgery. So that fear is kind of unsubstantiated, but you should know what you are treating. I mean, even if you're doing an IMRS, you're not really going to give any constraint to them. The other thing we often ignore is the dose to the ventral and cochlear nucleus, the ventral and dorsal cochlear nucleus. Now, these nuclei are not going to be visible on the MRI. You have to have a knowledge of the morbid anatomy to know where they are in relationship to the tumor. There is one paper by Peake et al. Which suggested that the ventricular cochlear nuclear dose is one of the things that if you can keep the dose below 9 gray for SRS, the chances of hearing preservation is more, which is possibly just as important as the cochlear dose as well as the auditory nerve doses. Pre-treatment preparation. Well, of course, you have to have the audiometric test. If there is no, in the Robertson-Gardner system, if you don't have less than 5 decibel PA and more than 50% speech discrimination score, then this patient don't have serviceable hearing, and there is no point taking this patient up for radiation. The 7th nerve function, the facial nerve function, should be documented, though the chances of damage through radiation is very, very less. But for the sake of documentation, that what is the pre-treatment weakness of the facial nerve through the House-Brackman score, all of you know, I would assume. The role of pre-treatment steroid is kind of controversial, and especially for fractionated radiation therapy, there's not much of a role of that. Well, the sequelae of the steps of the treatment, these are identical, whether you are doing a single fraction radiation, 5 fraction radiation, or a 20 fraction radiation. By and large, they're identical. You have an immobilization with mask or frame. You have to do the MR and the CT with 1 millimeter cuts with contrast and fuse them. You contour the target and the organs at risk, and the planning. The planning technique in today's computers, there are plenty of approaches by which you can do it. Of course, you have the gamma knife on one hand, you have the cyber knife on one hand, and my experience is primarily with the Nuances system, which is a radiosurgery dedicated towards this radiosurgery system, which can use either static conformal beam, IMRS beam, dynamic arc, hybrid arc, everything. One has to be completely agnostic of the technique, because every tumor shape, size will determine what sort of technique you're going to use. There are absolutely no differences. So if somebody is telling you that gamma knife is superior to LINAC or LINAC is inferior to gamma knife, that's crap. What is important that you should be able to deliver the desired dose, whichever technique you use, to the target without crossing the tolerance of the surrounding structures. That's about it. These are tools. You have to pick your tool depending on the kind of job you're going to do. This is one of my most favorite photos. This was back in 2010 when we started doing fractionated radiosurgery in my hospital. And this photo predates that photo by about 3 years. And you can see me much younger and possibly more handsome back then. When we fitted one of the frames to our first patients, the frame is gone. We don't use this anymore. Practically, we have not used a frame in the last 7 years. Once you have got the CT and the MR image. Fusion is done by the software usually, and I will not go into the detail because the softwares are different from each other. What is important to understand that MRI has got inherent problem in their distortion correction, and it is not possible to fuse an MRI with a CT 100% across the entire brain volume. Therefore, it is imperative that you actually fuse the volume accurately at the level of the tumor. And if you have inaccuracies at other areas, you need not bother about them. And the primarily treatment will be done, the calculation will be done on the basis of the CT scan. Image matching will be done on the basis of the CT scan. Your CT scan picture quality should be paramount. And the MRI has to be fixed to that. MRIs are usually, all the sequences are usually TICOM matched. So once you fuse one MRI sequence, rest of them will automatically get matched. So if you fuse the T1 contrast, the T2 and the flare and the CIS protocol will automatically get matched to the CT scan. So that's not much of a problem there. Since I use the ExactTrack system, I have shown what is the way of verification of the position. So ExactTrack takes a couple of X-rays in an orthogonal plane, oblique orthogonal plane, and it matches with the DRR with the help of software. And if the matching is perfect, then you will have no deviation, and you know within 1/3 of a millimeter accuracy you are there. If it is not, either you can override it manually or you can allow to do it a rematch till you get it. One of the advantages of using a frameless image-based system is that if you are having multiple beams, which you have, you can always do this matching halfway through. Which means you take one photo. Which means you take one photo before one beam, and then take another photo before another beam. And if there is any change in the position because of any reason, you can immediately correct it. So that is one way I feel that this is a really beautiful thing, because once you are using a frame, any error that has come in, there is no way to know. For the residents, and I have been told that most of the people who have logged in today are radiation oncologists. Radiation oncologists are generally good at radiology, but if you're not, you have got no business doing SRS, SRT. You simply cannot depend on your radiologist. So you should know the anatomy pretty well, and the location of the cochlea is anterior and medial to the IAC. And how do you know it? For some reason, this is a question that all residents ask you. How do you see it? And this is a typical working picture for you. This is what you will see. And this software is the iPlan, which is a commonly used software. You can see this is the T1, this is the T1 contrast, this is the bone window of the CT scan, and here is the T2. For us, possibly for the cochlea, these are the two most important, because you can see the cochlear location in the CT bone window very clearly, and you can see a hyper intense area in the T2. So this is where you draw. I don't know if you can make this out. This little blue thing is what you have drawn here in all the bone windows. So typically it will be in 3 to 4 bone windows. If you have taken 1 millimeter cuts, 3 to 4 bone windows, you will be seeing them. Draw the cochlea. I personally draw the cochlea in the bone window because it's the easiest. And if it matches subsequently in your T2 and your other sequences, you know that your fusion is perfect. If your fusion is slightly wrong also, you will not be able to get this and this match together. Now, mind you, these fundamentals are not related to SRT, but SRS as well. They are fundamental to both, whether you're using a short fractionation or a long fractionation. Similarly, you have to draw the structure. The structure I prefer to draw, or anyone would prefer to draw it on the T1 contrast, because we saw that the T1 contrast will brilliantly enhance. T2 contrast will, the CT contrast will also enhance. So these are the ways of matching them. You would match them with the T2 to see what is the relationship with the cochlea. You should match it with the CT bone window to see what is the relationship with the IAC. But primarily the tumor is drawn in the T1 contrast. Also, you have to draw the midbrain. Midbrain you can usually draw in the T1 contrast and verify with the T2, because here you have the interface with the CSF, so you know that you are in the right place. And this is the thing that you have drawn, all the structures, the main structures being the tumor, the cochlea, and the midbrain. These are the key things that you do. The 5th and the 7th nerve, if you have got a good image, please draw. Please draw, because otherwise tomorrow somebody comes up and files a case to you, telling that you did not even bother about what happened to my 7th nerve or 6th nerve, you should be able to provide a document that you have actually seen it. But will it be a part of your treatment planning consideration? No, because they are so intimately related to the tumor that you will not be able to play around with the dose that are going to the 7th nerve and the 5th nerve. Now, what sort of dose constraint you will use for a fractionated one? Descriptions of 45 gray to 54 gray has been described. Of course, you can give 20 gray in 21 gray in 3 fractions, and you can give 35 gray or 30 gray in 5 fractions. They can be given. They all fall in between. As I told you, it's a continuum. But since my topic is SRT, I have tried to focus on the fact that 45 to 54 gray is a standard dose, and the cochlear dose variably should be limited within a 35 to 45 gray. Some people have described 35, some people have described 45 gray, depending on how much of hearing loss you want to accept as a cutoff. That way, it is in radiation oncology we call it ALARA, which was as low as reasonably achievable, and other things are basically applied to the 20 gray and the 3 fraction, the 5 fraction arrangements, where the Timmerman paper is very, very important. That can tell you that 20 gray in case of a 3 fraction or 27.5 gray in case of 5 fraction is an acceptable cochlear dose. As I have started late and I was told to finish off quickly, I will not take my 20 minutes time and I'll finish up before this. So these are the basic things about the choice of the cases. And if you look at the data, how it stands out, you will realize all the authors who have offered data for both SRS as well as SRT, these are not randomized data. These are by and large cases which have been retrospectively analyzed, and therefore this data is not consistent. You cannot draw any conclusion out of them. It is just for the knowledge that you know that the hearing preservation is kind of all over the place, because in this case you see this is 33% and in this case you see 65%. Can you draw a conclusion that SRT is better in hearing preservation? The answer to that is no, because you don't know what was the initial hearing. The cranial nerve 7th and the cranial nerve 5th toxicities are kind of range bound in the range of 3 to 4%, 5%, which is generally acceptable. But the purpose of showing this is that people have used over many years, over 10 years, they have used different kind of approaches, especially once the linear accelerator based SRT became available, the interest in fractionation went up. But we have not been able to produce a meaningful data. Now, the reason for that is that the number of the patients needed to do an FS for SRT over 5 weeks, you simply don't have that number. It's a very small cohort, and I have in some 12-13 years of doing SRS in my present hospital, I have done maybe not more than 2 or 3 cases of fractionated SRT in a whole year. Most of them will ultimately veer to a short fractionation, as short as you can possibly do, and I will show you why. These are the single author series, and this is a pretty comprehensive single author series where they have got a very well number of 100, 80, 50 patients, and they are there from 1996. But one thing you will notice that you do not have any recent data. You don't have the data from last 2 years back or 3 years back. The reason for that it is not a thing that people are considering for investigating anymore. It is a kind of a done deal now, and you will show how. I will show you how. So if you see, people have, for a well-chosen case, you have nearly 100% local control, which is what you would expect. Useful hearing, whenever it has been reported, it is 100%, 70%, but then you cannot really, make a meaning out of it unless you know what was the initial hearing. So for example, in this particular set of patients, if you don't know what was the initial hearing, you cannot just call this off telling that, oh, SRT will give you less hearing preservation. Cranial nerve injuries are very, very rare. Now the postulate behind fractionation is that if you fractionate, the nerve injuries are going to be less. However, Dr. Debulking was very nicely explaining that the hearing loss is a multifactorial thing and it is not clearly understood. Though we say that dose limitation is one of the factors, but whether it is the only factor we don't really know. And therefore, many of the patients who have undergone SRS, they over 5 years' time, without any improvement without any increase in the size of the tumor, also will slowly lose their hearing. So this is a multifactorial thing, and therefore one should not obsess too much about it. But whenever possible, one should be keeping in mind about this. So what is our present recommendation now? The present recommendation as it stands on 2017, and I have not found any evidence beyond that. The Congress of Neurological Surgeons Systematic Review and Evidence-Based Guidelines on the role of radiosurgery and radiotherapy on management of patients with vestibular schwannomas, the recommendations are somewhat sad. What does it say? It tells you, it asks the question that is there a difference on the basis of the dose delivered, whether 30 gray in single fraction, whether 25 gray in 5 fractions, 36 gray in 6 fractions, 50 gray in 25 fractions. Is there any difference between them? The answer to that is no. There is absolutely no difference in the outcome in the radiographic control, irrespective of the kind of dose or fractionation that you're using. Same thing with the number of fractions. Is there any difference on the basis of the number of fractions? There cannot be any recommendation for that. Now, that does not mean that SRT is bad. Please understand how these numbers are stacking up against each other and how this evidence is explained. It does not mean that SRT is bad. It merely tells you that we have not done the amount of scientific studies that should be done to answer this question in a coherent manner. This is what it means. Now, does it mean that from tomorrow you will not do any SRT for any of these patients? The answer to that is also no. What it means is that all the things being equal, you should try to finish off your treatment as quickly as possible. And if it is a single fraction, perfect. If it is 2 fractions, 3 fractions, 5 fractions, excellent. But if a patient is there who cannot be fitted into any of this single fraction, 2 fraction, or 5 fraction, what do you do for this patient? For these patients, a fractionated SRT over 3 to 5 weeks is still a valid and a very, very safe option, which would have otherwise not been possible to treat with any other fractionation schedules. And I will illustrate the point.
Dr. Koushik.
Yeah.
Sorry to interrupt. I think you should now wind up the.
Yes, last slide, conclusion slide.
Okay.
So question is that where do you consider FSRT or SRT? So very, very large tumors where you have more than 20 cc, where you have intracanalicular extensions, when you have mid-band compression, or if it's a retreatment. So I have only 2 radiological images. This is a 75-year-old male with a moderate hearing, with severe ataxia, and there's a history of SRS 6 years back. Patient tumor is small, but we did 2 plans with IMRS and static conformal. It showed that you can have a better outcome of coverage versus the cochlear dose in the IMRS, and such a dose was chosen. The second patient is the last patient here. You can see this is the kind of tumor that you simply cannot treat with radiosurgery single fraction. So this patient received a full dose of 50 gray in 20 fractions, and these are the odd kind of patients that will not be very common, but when they come, you cannot treat them with anything apart from a protracted 5 weeks of treatment. So this is the summary. There is no level 1 evidence. The data is mostly retrospective and prospective single-arm studies, and there is no major outcome differences. Both the outcomes and toxicity profiles are excellent. Therefore, it may be considered to be safe in large tumors with mid-band compression, intracanalicular extension, retreatment. On the basis of the existing data, you cannot make a high-level recommendation in favor of one over the other. So choose the most convenient schedule for the patient with the safety duly considered. Thank you.
Thank you very much, Dr. Koushik. That was a very succinct presentation of all the data and lack of it as far as radiation is concerned. We're running out of time, so I will now request Dr. Shankar, who is the moderator for this webinar, to take over, and then I'll come back and make some closing remarks. Dr. Shankar, please.
Question for Dr. Goel. If Dr. Goel is there on the line?
Yes, I'm there.
Yes, sir, there is a question. 2 questions are for you. Dr. Goel, sir, please explain some techniques for facial nerve preservation. What is it that you are practicing?
Yeah, this is not just a question. This is a lifetime job. If you have to know how to facial nerve preservation, you have to spend years of dedication, years of hard work, years of commitment to the subject, several cases, more and more experience. I think there is no one sentence treatment, some one sentence recommendation as to how to save the facial nerve. Your dissection has to be meticulous, your dissection has to be quick, your coagulation has to be minimum, your tumor handling has to be perfect, your tumor demolishing. You see, what I say is, you have to learn the art of breaking the tumor. You have to learn the art of demolishing the tumor. And you have to have the feel of operating in a bloody field. And whilst you are operating, you have to have your third eye in complete contact with the subarachnoid spaces. And you have to get to the facial nerve on the brainstem side, on the proximal side, and you have to do everything. You see, facial nerve is a lifetime work, and I hope you agree with me. So what is the second question?
The second question is, in cases with acoustic tumors presenting with raised ICT ataxia due to hydrocephalus, do you advise a preoperative shunt?
Now listen to my question, answer very carefully. You see, shunts were done on a regular basis earlier, and I not only don't recommend shunt, I have a feeling that if the patient has been shunted beforehand, it is going to make my surgery absolutely difficult. And shunt should not be not only not recommended, it should not be done. The thing is, what you have to learn is, even in large tumors, these are benign tumors, these are slow growing tumors. The subarachnoid spaces are quite large. You see, if you know the knack of opening the cisterna magna early in the operation, you have to know. If you cannot know, if you do not know the art of opening the cisterna magna early in the operation, then probably you will need some other kind of CSF diversion or things like that. But the question has been directed to me, and my answer is no. I have never done preoperative shunts. That is my answer.
Yeah. So RajShekhar sir, you're there?
Yes, I'm here.
Yes. So there is a question for you.
Sure.
The question is, can SRT, the NF2 imposes high risk for RT-induced carcinogenesis in brain tissue. So it is wise to put SRS at first line option for NF2 in early stage.
I didn't get the question. So the question being asked?
Neurofibromatosis partially increases the risk of RT-induced carcinogenesis.
Slightly, yes, it does.
Can we use radiosurgery as one of the frontline options in early stages?
Absolutely, you can still go ahead, provided you counsel the patient that there is a very, very small remote chance of the tumor turning malignant transformation, but that's very rare. But you don't have too many options with NF2. So I would still go ahead with the SRS for the smaller tumors, but for the larger tumors, I would do SRT. But the small tumors, SRS is a very valid option for NF2.
Shankar, can I add to that question?
Yeah, Koushik, there is a question for you also. SRT.
Okay. So the 2017 neurosurgery conference recommendation that I just alluded to, that made a observation about the NF2 patients, and it observed that there is no scientific data to feel worried about the incidence of malignancy in these patients. So it is not a contraindication. If a patient is a case for radiosurgery or radiotherapy on the basis of its clinical merit, you should go ahead without really considering that as a risk for it.
Yeah. So
all right, Dr. Shankar, I think we're running out of time. So we need to
one last question. One last question. So can I take one question, sir? Last question.
Yes, please go ahead.
One last question, sir, because there are 3 questions. Is ma'am there? Shilpa ma'am there? Shilpa ma'am.
No, she's not there.
She's not there. Okay. So, Dr. Dti Imaging, you have one question. In which frequency you advise to do follow-up where no intervention is the plan? Probably observation. That is the clinical follow-up. I think that was already told. Would you like to just summarize it? When you would advise for observation in
if I am observing a patient, I would follow up on 2 counts. One, of course, is imaging, which is about 6 months apart, and second would be hearing. And I would warn a patient that if hearing clinically gets affected earlier, then they should follow up earlier. but otherwise 6 monthly follow-up for the first 2 times. And thereafter, if it is really a stable or a stable patient in an old, stable disease in an old patient, I can follow up once a year. In younger patient, first 2 visits at least 6 months, and then maybe yearly visits.
Fair enough. I think there were some questions on pseudo progression timing, whether we can do it at 2 years, because there are, as I said, the routine. There was a question on a pseudo progression in post radiosurgery patients. So just to clear the air, in 86% of patients, majority of the time it happens in 6 months. 6 to 8 months, what we see. Yeah. In around 12% of patients, it happens anywhere between 3 to 4 years. The question is why it happens. You know, honestly, we have no answer for this. As what happens really at the cellular level due to surgical doses of radiation. So, yeah, at the end of the day, if we are seeing some pseudo progression at 3rd or 4th year, I would still not rush in to go and offer some kind of salvage therapy. We have to just wait and watch to ensure that radiation effects fully kick in. And in all these patients who are put on follow-up, there has been a very consistent decrease in the size and a good local tumor control. Thanks much. And let me summarize. I would like to thank all the speakers, Dio Pujari sir, Goel sir, Turel sir, and of course we missed out Dr. Basant Mishra sir. And Koushik, wonderful guy. Thanks for plugging in at the last moment. And of course, Sudheer is there, my close friend, and Shilpa ma'am. Thank you so very much for the time you have spent for educating the radiation oncology community. I'm sure around 50 to 60 neurosurgeons are also logged in. Happy to share that there are around 550 registrations which have happened, and I've listened to the lecture which all of you have given. And thank you so very much, sir, once again. And Kilara sir, would you like to conclude?
Yes. First of all, my compliments to Dr. Shankar once again for putting together this webinar, which has over 500 registrations, which is a fantastic thing to happen. It's almost like a regular conference. Second, I'd like to thank all the speakers for the wonderful way in which they have presented their case and given us so much of information. I mean, even for a radiation oncologist to get so much of information from the neurosurgeons who also practice gamma knife was indeed a very, very good part of this whole thing. I don't think the debate over radiation, stereotactic radiotherapy versus surgery has yet been settled, because as surgical techniques have improved, so also have radiation techniques improved. The coming of the CyberKnife, for example, allows you to give very high doses of radiation, and this hypofractionated radiation, the biology of the tumor would tell us, would be much more effective than the conventional fractionations that we are doing. Of course, it's still early days. We need comparative studies to come in, but I'm reasonably confident that radiation oncologists can do a very good job with proper selection of cases and having the technology at their command. I'll wind up by thanking our IT person, Mr. Rakesh, for doing a wonderful job. We did miss Professor Mishra's presentation. Unfortunately, we couldn't get the technology together, which makes me feel actually, I'm very technologically challenged. So when I see that others are also challenged, it gives me some kind of a vicarious comfort. Having said that, thank you very much, everybody, for joining in. Thank you, Dr. Shankar. All the very best. God bless you.
Thank you, sir. Thank you, sir. RajShekhar, sir. Thank you. Turel, sir. Goel, sir. Dio Pujari, sir. Thank you. Thank you, Koushik. Bye.